Honorable Minister, distinguished guests, ladies and gentlemen, all protocol involved, good morning again. Welcome to the first Rwanda Science, Technology and Innovation Conference. I'm Eva Liliane Geneza. I'm a lecturer of mathematics at the Rwanda Institute for Conservation Agriculture, and I'm a researcher affiliated with the African Institute for Mathematical Sciences. It is a great honor for me to welcome you to this conference today. The theme of the conference is leveraging the potential of science and technology to mitigate challenges associated with COVID-19 pandemic in developing countries. The first case of COVID-19 in Rwanda was discovered in March 2020. It has been 2 challenging years during which a lot of lives were lost. Some people have learned to live with persistent symptoms, and long after they have been able to clear the infection. We have a lot of people that lost their jobs or experienced job disruption. However, despite all these challenges, we have also witnessed a spike in science and technology-based innovations, all aimed at mitigating the impact of the pandemic from all sides of the globe. In Rwanda in particular, we were able to see that we developed smart robots that were used for contactless screening of COVID-19, and these were dispatched at the airport. We have seen cashless payment methods being improved and reinforced in order to avoid the exchange of cash and curb potential infections. We have also seen an improved algorithm for pool covering testing that was developed and implemented in order to increase the testing capacity of the diagnostic labs. So all these spectacular achievements and many more were all the result of the hard work and collaboration of talented scientists and experts from various fields. However, we are not out of the wood yet, as there are still multiple issues that still need to be solved. For instance, despite the proven efficiency of COVID-19 vaccines, the accessibility and administration is still lower in developing countries compared to developed countries. The socio-economic and public health impacts of implementation of various pharmaceutical measures that have been implemented by various countries to limit the spread of COVID-19 are still not well established nor quantified. There are a lot of other issues that have not been resolved yet. Thus, this conference, organized by the National Council for Science and Technology today, was organized around this theme. The conference will last 2 days, during which we will hear from international experts, senior and junior researchers, about how they use science and technology to mitigate some of the challenges associated with COVID-19 in developed countries and in Rwanda in particular. The conference is made up of 5 different sessions. We will have 3 sessions today, and the 2 others will be held tomorrow. Today, our first session will be the welcoming session. We started already with the registration, which we have all been through, and COVID-19 testing. As you have seen outside, we also have an exhibition, which we continue to look at in a few hours. After this introduction, I will call up to the conference organizer, the chair of the Scientific Organizing Committee, and the leadership of NCST and our guests of honor to give us their welcoming speeches. So before we actually get there and we start, I just wanted to also mention that we will have health breaks around 9:15. I guess we will change the time. We will let you know the due time due to the little delay that we have experienced. But we'll have a health break during which we'll have some coffee and tea outside. And also we'll continue with the exhibition session. In case you have any questions or problem or you require any support during the conference, you may walk on the back of the room. Some of the organizers will be there. You can read on their badges. It's written organizers, and they will be able to assist you with whatever request you may have. All right. So now let's kick off this conference with a speech from the welcoming message from the chair of the Scientific and Organizing Committee. This is Dr. Maru Chantal Chiurinyana. She is the Science and Technology Foresight Analyst for the National Council for Science and Technology. Please give a round of applause to Chantal.
Good morning, everyone. Wow, the room is full now. I am so happy. The day is here. Honorable Minister of Health, distinguished guests, varied guests, online and in person, welcome and good morning again. It is a great pleasure for me to be here and share with you the scientific view in our field on how we, as Rwandan and people from developing country, has put the force together and the brains together, science together, engineering together to get the solution to mitigate COVID-19 pandemic, which really shaped our life. As you know, today we started the session or the series of conference that we call Science and Technology Innovation Conference. So this is the first of a kind that Rwanda has organized, and has been organized in collaboration with, so the host and the brain behind is the National Council for Science and Technology, but with its stakeholders, namely Rwanda Biomedical Center, University of Global Health, University of Rwanda, African Institution for Mathematical Sciences, Carnegie Mellon University, University of Global Health Equity. So we are the organizer of this conference, and I know that you are going to enjoy it. The theme is ever mentioned. It is leveraging the potential of science and technology to mitigate challenges associated with COVID pandemic in developing countries. This conference is going to tap on different themes. The first theme is on the role of science and technology in addressing COVID pandemic. The second one is going to be on building resilience to crisis and to mitigate the impact of COVID-19 pandemic. The third one is predicting and monitoring impact COVID pandemic. The fourth, public health and COVID-19 management, innovative key consideration. And the last one, vaccine and the future developing country COVID pandemic crisis. So we have received various abstracts from various renowned scientists, but also people who are going to to present today the abstracts in those 5 themes. We have been privileged to have among us the keynote speaker, the well-known 6 keynote speakers who are going to share with us the experience and how also they tackle those 5 themes. So we also have authors of oral presentation. We have also authors for poster presentation. We also have different exhibitors who are going to share with us what's the status of science technology in developing countries this day. This is an opportunity to network, because I have seen different faces in this room, and people, due to the COVID-19, we were all doing these conferences online, but today we had a privilege to sit together and see the face-to-face. I have been seeing people online. Now today I am happy that I'm seeing you face-to-face. So we are going to have an opportunity for scientists, researchers, engineers, academicians, and students from all over the nation, because online we have different people who couldn't make it because of this COVID pandemic crisis, which couldn't permit people to come on time. This conference is rich and variable in various ways. As I was talking about the paper presentation, oral presentation, we are going to have rich oral presentation. There are going to be 19 in those 4 sessions that they have mentioned. Today we are going to have 2 sessions. After the break, we are going to start to kick off with the 2nd session. And we are also going to have outside 7 poster presentations, but the other online ones also will be online. And we have 10 exhibitors. We have our 6 keynote speech. 2 will be online, and 4 will be physical. During this conference, we will showcase progress of scientific program and incredible visibility of institution. So that's why we have some exhibitors from different institutions, companies who are going to demonstrate what they have been doing during this time of crisis. During the conference, there will be also an important event. We are going to have the awarding ceremony. We are going to award 4 people. We are going to award Distinguished Research Achievement, the Best Female Award, and the Distinguished Science and Technology Award, and the Rising Star Award. So meaning that those are going to be presenting, they're going to be also being evaluated with, by our scientific review committee. The science committee also afterward, after this conference, is committed to take the best abstracts and paper and try to select a good journal where they can be published. We have also set out some anticipated outcome for this conference. So the proceedings, including data on digital divide and data on key gap to address COVID-19 and other health threats in developing countries. So we are going to have this data, and some report will be written on that through the conversation that we are going to have in this conference. We are going to have a strategy and program to drive sustainability evidence based on program addressing, because due to the conversation that we are going to have, I think we are coming with a plan and a strategy to this. Then we are going to provide the awards, as I said. I think this is a good opportunity to share our views on how we did to mitigate COVID-19 and how the science and technology has shown that we can do more, because I know that we are going to enjoy this conference. Let me not take a long time. I'm going to give the mic to the moderator, and I wish you all a good present here and to enjoy the conference. And thank you so much for being with us. I can see the room is full, and I'm happy. Imagine that you have a ceremony and you don't have people to to eat your food or to enjoy what you have prepared. So I'm very happy that you respond to our invitation, and I am ensuring you that you are going to enjoy. Welcome once again.
Thank you so much, Dr. Kyurina Marie Chantal, for the very warm and engaging few notes. So now we are going to have the welcoming remarks from Dr. Eugene Mutimura, the conference host, and the Executive Secretary of the National Council for Science and Technology. Once he's done with his welcoming notes, he is going to call up to our guest speaker, the Honorable Minister, Dr. Ngamije Daniel, the Minister of Health of the Republic of Rwanda. Dr. Mutimura, please, the floor is yours. Please give a welcome applause for him. Thank you.
Honorable Minister of Health, Dr. Ngamije Daniel, our guest of honor, distinguished keynote speakers for our conference, distinguished participants and presenters for our conference, leaders of various institutions, both public and private institutions, distinguished ladies and gentlemen. Good morning and welcome to our conference. It is my pleasure to welcome you all to this first Rwanda Science, Technology, and Innovation Conference 2022. As you have noted, the theme of this conference is leveraging the potential of science and technology to mitigate challenges associated with COVID-19 pandemic in developing countries. This conference is an essential platform for us as scientists, leaders, to demonstrate scientific progress using technology to address COVID-19 crisis, and has reminded us several things. Let me mention only two. First, the crucial contribution of science and technology in addressing health challenges, but also supporting the society and economy in times of turmoil. Second, the importance of collective demand for scientific expertise and coordination. Distinguished participants, this conference has attracted abstracts from several countries, such as Cameroon, Ethiopia, India, Ivory Coast, Kenya, Nepal, Nigeria, Rwanda, Senegal, Sri Lanka, Tanzania, Uganda, only to mention a few. We would like to assure all our participants that they will enjoy this scientific conference as a memorable event on advancement of science and technology, such as the use of artificial intelligence, data science, and robotics to fast track and improve COVID-19 management, containment, prediction, as well as improving human health through vaccination. Dear participants, we are very, very grateful to the government of Rwanda for supporting this conference. This is the first Rwandan conference on science, technology, and innovation to provide an opportunity for global scientists to deliver on key important areas of digital divide and the key data gaps to address COVID-19 pandemic. We have also an opportunity that selected scientists who have benefited from Rwanda's funding will present their research studies. As part of the current funding for over 90 projects across all disciplines, for approximately over 4 billion Rwandan funding commitment. Allow me, ladies and gentlemen, to express our gratitude to the members of the Scientific Committee who have done incredible work to ensure a successful event. Let me mention their names. Dr. Marie Chantal Churinyana, Dr. Japhet Nyobuhungiro from the National Council for Science and Technology, Professor Bideri Nyamurinda from University of Rwanda, Ms. Noera Bigirimana from Rwanda Biomedical Center, Professor Timothy Brown from University of Carnegie Mellon University, Africa, Professor Matt Ames from University of Global Health Equity, Dr. Isambi Silo from Ames. This team has done incredible work from the time of announcement, selection, at the time where we are. We want to thank them and allow me, ladies and gentlemen, to clap hands for them. There come also important members and renowned keynote speakers that we cannot fail to mention because they are going to present this conference and share with us a lot of their expertise across various themes as the chair of organizing committee has indicated. Let me mention their names also. Dr. Roger Glass, the director of Fagate International Center at US National Institute of Health. Professor Agnes Binagwaho, Vice Chancellor and Professor of Pediatrics at the University of Global Health Equity. Dr. Kelvin from University of Dalhousie in Canada. Mr. Stefan Leslie, Chief Executive Officer, Research Nova Scotia in Canada. Dr. Claude Mambo Mvunyi, Director General of Rwanda Biomedical Center. Dr. Wilfred Ndifone, Chief Scientific Officer at African Institute of Mathematical Sciences. And Ms. Melissa Rusanganwa, Head of Africa Regulatory Affairs Zipline, who is going to be part of the moderation and panel discussion tomorrow. Ladies and gentlemen, allow me to finally thank you for being here, being able to attend our conference. And indeed, our goal and hope is that this conference takes place at least every 2 years, with diverse, prestigious awards conferred to highly deserving basic scientists and researchers in a well-publicized gala events. Looking ahead, each of us has a vital role to play, shaping COVID-19 recovery to a new normal life, placing health and equity at the heart of all programs and policy. I thank you. Ladies and gentlemen, allow me to welcome our guest of honor. I have the privilege to welcome our guest of honor, Honorable Dr. Ngamije Daniel, to come and provide remarks for this conference. Honorable Minister, most welcome. Let us give a clap of hands.
Executive Secretary of the National Council for Science and Technology, distinguished keynote speakers, Vice Chancellor, Rectors, Director of Higher Learning Institution, Director Generals, CEOs, Managing Director of respective institution, country representatives and managers of development partners, institutions, and agencies, distinguished guests, ladies and gentlemen, good morning. It is a great honor for me to join you for this first Rwanda Science and Technology Innovation Conference today to discuss a pertinent theme, leveraging the potential of science and technology to mitigate challenges associated with COVID-19 pandemic in developing countries. Allow me to begin my remarks by thanking the National Council for Science and Technology and its stakeholders for organizing this conference. With this, I'm pleased for this opportunity to share with you the status of COVID-19 in Rwanda and future directions. As we know, the pandemic began in December 2019, and it was declared a pandemic health emergency of international concern by WHO in January 2020. In Rwanda, at the beginning of this pandemic, we built on previous Ebola preparedness to develop COVID-19 preparedness and response plan for surveillance with required all components of this comprehensive tool, which was used to mobilize resources and engage the entire population. We established coordination mechanism from high level up to the centralized level to make sure that everybody is part of actors to fight this pandemic. We invested and we continue to invest in primary health care as a foundation of handling the pandemic in some key areas, such as human resource, data use, supply chain, among others. During this pandemic, we established private sector collaboration for manufacturing health commodities, including hand sanitizers, masks, PPEs, face shield, and soon, manufacture of syringes will start its investment in Rwanda. We also enhanced consistent and continuous community engagement throughout prevention and overall management of the disease, and as outcome, vaccine hesitancy is not our main concern as of today. We transitioned from systematic isolation of patients and their contacts to home-based care so that we can reduce expenses related to pandemic management. We use deliberately technology solutions including robots, drones, bracelets, GPS as tracking system for cross-border trucks, and also several digital software. We use the latest data to provide timely, accurate, and targeted decision. As most of you observed it in the cabinet resolution and in several ministerial instructions related to COVID-19. We had opportunity to strengthen our health system to make sure that it's more resilient, responsive to future pandemic. Some strategic investments were made, like in building our laboratory capacity by decentralizing PCR testing capabilities, proceed with genomic sequencing, and train staff. We also invest in expanding ultra-cold chain capacity. And for this reason, we're among few countries at the beginning of this pandemic to receive vaccine which required ultra-cold chain condition for conservation. We also invested in production of and supply of oxygen in renovated and expanded intensive care units in all provincial hospitals and some district hospitals. Finally, we reinforced Rwanda FDA as part of government strategy to attract investors in pharmaceutical industry. As we look ahead to leveraging science and technology in the pandemic, especially for developing countries, we aim to improve our data system to handle future pandemics, including sub-regional data sharing, but also leveraging technology and knowledge transfer in vaccine production with required upskilling Rwandans, operators, and scientists who will work closely with biotech partner in mRNA vaccine production for COVID-19, but also for other endemic diseases. We rely our partnership, such as for this conference, on maximizing the use of science and technology in guiding intervention for public health matters, such as integration of wearable devices to easy and monitor physiological changes, use and interconnected digital medical tools for detection of NCDs in screening corners, like in supermarkets, pharmacy, public institution, to track NCD trends and generate big data to inform health policies. We also use internet systems to share real-time data across existing platforms of health information, such as Health Information Management System, Lab Information System, Logistic Management and Information System. Distinguished guests, as I conclude, allow me to recall that our future will be marked by scientific and technological progress, which can only be achieved through collaboration and transformative partnership. In particular, the government of Rwanda will continue to provide necessary support to integrate the potential of science and technology, research, innovation, in order to improve healthcare services delivery, well-being of population, and support evidence-based policies. I thank you.
Thank you, Honorable Minister, for the great guest speech. So in the next few minutes, we will have a photo session. But before we move to that, I would like to highlight a few activities that are going to take place during the conference, as well as point out a few logistical details. First, I would like to mention and to bring to your attention that tomorrow there will be an awarding ceremony during which awards will be provided in 4 different categories to the best paper presentations. We will also tomorrow have a gala dinner, so please keep that in your calendar and get ready to participate. It's going to be very interesting and awesome. Lastly, I wanted to remind you that we do have the exhibition still happening outside. So as we move towards the picture session, those that will not be involved, so the picture ceremony, the picture session is going to be mostly for the keynote speakers, the scientific organizing committee, and oral paper presenters. So after the pictures are taken, we will go outside. There is a half break with coffee provided. And please do take the time to mingle around and discuss with the poster presenters as well as the exhibitors from the various higher institutions of education, as well as governmental institutions and private institutions that work on tech that is being used in public health. So for the photo, I would like to call up to Honorable Minister, Dr. Ngamije Daniel, to come ahead with Dr. Mutimura Eugene, the Executive Secretary for NCST, as well as all the keynote speakers. So please make your way here to the stage for the picture. Professor Agnes Binagwaho, Professor Claude Mambo, Professor Wilfred Diffon, Professor David Kelvin, and Ms. Melissa Lusanganwa. Thank you. All right, I would like to ask the members of the Scientific Organizing Committee to join in as well. Professor Timothy Brown, Dr. Isambi Ceylon Balawata, Professor Matthew Ames, Professor Videli Nyamolinda, and Dr. Jafet Nyobohongilo. You can go in front, I think. I think some people can stay in front, maybe. Everyone presenting a paper with an oral presentation, please join in the group. Everyone, please stand here on the bottom. Stay in front. Everyone presenting a paper. Oh, that moves. All right, thank you everyone for your patience. Now it's time for our health break. We may go and enjoy our coffee break and mingle and network for the next 30 minutes. So please be back in the room by 10:30 as we will kick off the second session for the conference. Thank you.
Everyone here. I'm delighted to introduce Professor Agnes Benawaho as our first keynote speaker this morning on the topic of public health and COVID management, innovative key considerations for developing countries. Professor Benawaho is the Vice Chancellor and co-founder of the University of Global Health Equity. She worked as the Executive Secretary of Rwanda's National AIDS Control Commission, Permanent Secretary of the Ministry of Health, and Minister of Health. She serves as a professor of pediatrics at UGHE, senior lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, and as an adjunct clinical professor at Dartmouth. She is a member of multiple editorial, advisory, and directors boards, including the Rockefeller Foundation Board of Trustees. She is a member of the U.S. National Academy of Medicine, the African Academy of Sciences, and the World Academy of Sciences. She has published over 230 peer-reviewed articles and was named among the 100 most influential African women for 2020 and 2021. Distinguished guests, let us welcome Professor Benawaho.
So thank you, Matt, for this kind introduction. And dear Dr. Eugène Mutimura, Executive Secretary of, yes? Oh yeah, forgot this, you know. It became part of your skin. Huh? Thank you. Dear Dr. Eugène, thank you. And I'm very honored to come and give a keynote speech for this great conference, and very happy that you expressed to us that it will be at least every 2 years, because we need to come together to discuss and exchange on what we discover, what we would like to do, the challenges we have. So, dear friends and members of the scientific community from Rwanda and elsewhere, I'm going to talk to you about public health and COVID management, why innovation are key, especially for developing, yes, but it's too big for me. Do you hear me? So, it's okay. It's important, especially for the developing world. What I would like to share with you is how the developing world have contributed to create innovation that has helped managing COVID. So now it's 2 years, and I'm very pleased to say that it's the first time that I'm in a conference since the last 2.5 years when I'm not far from human being. And this is something that makes me smile and make me happy. And I have the feeling now that today we are in a cornerstone of the COVID pandemic. We are beating it. We have learned a lot during the COVID-19 pandemic. And we still have to assess what we have done, what we have learned. We still have a lot of lessons. That's why today it's an important day. I'm hoping that at the end of this presentation, you have an idea of how, for the health sector, it's important. There is no little innovations. You can go to the next slide. We have many areas of innovation. We have, of course, the technology, the laboratory, creating new medicine and vaccine. Digital health. Digital health is the future of health tomorrow that will help clinicians to provide better care. We have clinical innovation, how we treat patients, how we change the protocol, how we repurpose what we were doing. before. And after that, you have here what Honorable Minister Daniel have said this morning, governance. We undermined the innovation in governance. And if this country have managed so well the pandemic, it is because of its flexibility in governance, to do the instruction, the law, adapted to the need of the day. There were changes globally, regionally, and also locally. Next. So, first of all, let's go and talk about tackling health epidemic or health threats. You need first to diagnose and to confirm that there is an outbreak. Really define if there is more cases than expected, verify that they all have the same clinical sign, and planning for an investigation. There, we have got innovation, notably the fact that the COVID tests were discovered in less than 30 days. Next innovation will be how to make them available to low and mid-income countries on time, not only to link that to money. The second is case definition. Okay, we have this number of symptoms, too many people with those symptoms. What is the case definition? And what are the guidelines and the protocol that can be issued that will be changed over time as the health sector discover what this epidemic is about? And the investigation concerns the time, the place, where is it, and the people who is susceptible to get it. And then there was innovation by using e-tools for reporting that can be aggregated, and we all know that computer and so all those things help us to go faster in that field. The third is the recording of information. We need information, and I advise all of you to go and experiment this to the stand of RBC, because they have all the story how they disaggregate by demography, by geography, by clinical sign, and also we have to add the risk factors. That's how we knew that people with such a clinical underlying condition have to be vaccinated in priority because they are the most susceptible to die. And also, we need to understand the mode of transmission. That's how we all use this, and we did social distancing because we understood that we had to apply to this. And after that, we need to analyze all this, interpret the data, and according to that, do the right prevention and the right treatment, and social mobilization, explaining and communicating to the population what it is about. We don't have to take that for granted. I remember all of you, the human experience is most of the time subject of amnesia. Remember when mayors in Italy were running after the people, telling them to go home and to wear a mask during lockdown. So when we don't communicating with the population correctly, what happens is that they don't follow the good rules. You may have the science, you may have the lab, you may have everything. People will die anyway. So social mobilization is key. And here also you have good platform that has been used like Twitter, and in this country, that's how the Ministry of Health give information to the people day after day. Next. After that, we need to search the origin of this outbreak, especially in the country where it started, to make sure to stop the spread and also to avoid that new variant emerge from the same source. And here you have innovation with RNA sequencing that has been developed around the world. And after that, we have to confront your hypothesis and see how we can do to the context where the pathogen exists, and implement the prevention measure and maintain the surveillance. Like now, we are about to see the cure of the COVID-19, but tomorrow, we may face a new variant that brings us to 0 square. So we need to be very careful up to the time it's finished. So there's social media, and you have here what the Honorable Minister have said about what Rwanda have done. This is for box number 7, in the governance, the control of the measure, how you make it suitable to the population, and how you make all constituency buying. Next. We use at UJG to say that whatever you do in the health sector is about S's. I can give you 6. First is the stuff, meaning provision of vaccine, a respirator. You hear how Rwanda have equipped itself with oxygen plant. All these were innovation for this country. Of course, those innovations are going to help other diseases. Pneumopathia, that are killing people in Rwanda, will be less lethal just because we have more oxygen available. Neonate will die less because we have more oxygen available, and it was needed. You have also the staff, education, and also you need to research how to best educate the care providers, but also the population, the local leaders, the national leaders, the community health workers, and the volunteer. The third S is the S of system. You don't manage if you don't create a system, if you don't have a systematic approach. And here, you have here about the multi-sectorial command post at national level, district level, sector level, and also the role of the head of the village in identifying those in need of more support than others. So you have a system that allows you to apply the innovation and the scientific knowledge to save the people. The fourth S is space. Create the infrastructure. Like now, we go for vaccine development. Okay, we need to create factories. We need also to create schools to educate those who will produce or control this. So the space is important. And during COVID-19, the innovation here was to create special COVID treatment center. And it was very important because it was an unknown virus. We didn't really know how it spread from a human to human, or even we have found dogs with it. Is it contagious if your dog is infected? You can lock down people, but can you lock down dogs? So it's important to really innovate in space where you will treat people. The fifth one is support. You will see later in the presentation that in Rwanda, the innovation was to use existing mechanisms to identify those needed of support. And this mechanism was essentially Ubudehe and the village structure, head of village, and also to identify those who need support. But also what the government did, the relief say you may not pay your taxes now, we will see later when you recover your job. You have a loan to pay back your house. The government negotiates with bank for people to be allowed to skip some months without penalties. So the sixth one is sustainability, like the mechanism of pool procurement that has been initiated in Africa through, under CDC Africa and under the African Union. But here also, I just told you, oxygen plants, sequencing of virus across the country, not only into cities. So that means when you respond to a threat, you have to build your response to make sure that what you create today will serve tomorrow. Next. What is important, and this is not innovation, is the pre-existing system that you have created in between threats that have to support you now. It's the contrary. Has to support you to respond to a pandemic. And just the example of the health information system, that is a system that comprises 13 software that are interoperable. It took me 2 weeks to learn how to pronounce this word, interoperable. But it's so important because it helps those who manage a pandemic to triangulate, to understand we have more women sick there, or more men, or more people. What happened there? What is the causes? So you need to create your system to be resilient, can be adapted to response to threat from community to national. Next. So now you need to innovate in preparedness. You can see, this is a photo of somebody at UJG. We have starting January, when we heard what happened in China, we started to order everything that helped us, our lab, to create substance for disinfection, because we know that when it starts, all will be bad, and we will be, so we had our stock. Many institutions build their hand washing stations, and also to be prepared, ordering what it takes to measure your temperature. This seems nothing, but it's an innovation in this country that everybody, all institutions bought them. Normally it's the Ministry of Health and distribute that, and it's okay. But here we did it. So next. Other area to be prepared was the PPE. And you know the shortage the world faces. Also, we didn't know that there will be, we knew that we may risk lockdown, but many institutions were not ready for distance working, distance training. Hopefully, thanks to Matt and team, at UJG we were ready. And when the first case happened, remember, it was a Friday night. What we did, people at UJG were across the country. We say, you have to be here tomorrow afternoon. Everybody on the campus, we locked down and we continue to teach. We could do that because we had the teaching capacity that allowed us to teach at distance, even in one setting. There are other countries who did great, like Peru. You know, in Peru, the rate of killing women increased during the lockdown. So it was a public health threat. So they create a way to interview, to do police, and to provide judiciary advice, protection to women and children, e-based, across the country. Here in Rwanda, we are not near a port. So to get product inside, we had to protect the country against infection coming from other countries that were known as, that didn't take the same precaution that our country did. So GPS to all the trucks. And link GPS with COVID data so that we can trace where the truck driver that was infected has gone. So contact tracing using GPS. And also, the rest I have talked about this. Next. So isolation and quarantine also there was an innovation. Lockdown, no tourism, all the hotels empty. Where did we quarantine the people who were contact but healthy? In nice hotel. Yes, I had some friends who have been quarantined with the wife in. So that means you create trust with the community. People doesn't hesitate to come and say, I have been in touch. In other countries, because they will be penalized and they have to pay for that, they will not go to the authorities and say, I have been in touch with somebody. So, and the vaccine innovation, it was remarkable that we got a vaccine for this in less than a year. But you can understand also that different outbreaks have different response because of the pathogen behaving differently. Next. But we face some failure. Next. And I want to talk about them because those failures are against what we stand for, meaning social justice. Discovering the vaccine was quick, 1 year. Distribution of the vaccine, we are still reflecting on it. Why? Because the rich country didn't fulfill their promises. I don't talk about this country where we have the chance to have a leadership that really go across the world and modify. And because we were ready, we spoiled little number of vaccine, we have received a lot of vaccine. So we have more than 60% of our people vaccinated. But the rest of low-income countries, they reach 14.5%. And this is an inequity that we need to think about. It's good to have the science. It's good to have the private sector that invests in your science discovery to create medical tools. But if you don't manage to make people take those tools, you don't save life. You don't transform your scientific discovery in health outcome. Next. So implementation science is important, and all the teaching we are doing at UJG is based on implementation science. We have to remember that WHO alarmed the world late, declared an epidemic late, when it was already obvious that it kills a lot, and many countries were infected. In the beginning of the pandemic, not after, many countries act with selfishness, disregarding the union and not reflecting that if you don't control a pandemic together, you don't control anything. It happened in Europe, notably. When the first countries that were really overwhelmed with COVID didn't get support from others, and COVID was disregarded. I remember being in Belgium early, and I can say that I don't have to be politically correct, so it's okay. I was in Belgium at the beginning of just 7 days before the pandemic here, and there was an authorization for the kids to go in school trip in Italy, when in Italy they were overwhelmed by the pandemic. And those little kids were coming back after a week, and then the pandemic started in Belgium. When I saw that, I said, I'm better to go home. I was supposed to go to Indonesia. I said, no, I'm going back home. The world became crazy. But a good example to give is what CDC Africa did. 8 days after the first case on the continent, they call all the ministers of health and they decide on a protocol what to do for Africa. Next. Also, lack of courage and accountability of certain leaders who even say that they don't have COVID because God loves them, that they can treat COVID with a cup of tea. It's not, and this is not in one continent. You can see here Africa, Latin America, and the US. So this also, when you have selfishness at that level, you have lie, and the first time a virus was politicized at that level. Wearing masks was a political statement, not a scientific protection. So, and also scientific were publicly harassed, and lie became political truth. Next. There was also a failure of preparedness. Many countries were not ready, notably with PPE. And because they were not ready, there were acts of piracy. Really, when I say piracy, it's not a little thing. This piracy, you have some powerful states who divert masks for other countries against any laws. So this means that there is something that is being created now, which an institute to early alert in risk of epidemic and make sure to help countries to be ready. Because we have seen what happened when we don't have enough masks. We cannot save our people. Next. Also, there is the modeling. we have the Institute of Mathematics here. Modeling is an important tool for management. However, we need to revisit the way pandemic projections are done. You can see here the Global Health Security Index was saying that Africa will behave very badly, Europe and US will be very safe in case of pandemic. This was few months before COVID-19. And you say what happened. In this index that all the world was following, Rwanda was ranked 117 out of 195 countries. And you can see, next slide, that in reality, when we see what happened, Rwanda is ranked number 6 in the management of the pandemic. And those countries who are supposed to be number 1, 2, 3 are in the bottom. So that means we need to revisit the way we are doing projections and include other factors that were not included in so far. Next. But we go back to innovations. Next. I want to give the contact tracing. Notably, there is something that was created here by the African Institute of Mathematics, which is to save test and money and time. We take the sample of 100 people because the incidence was low in Rwanda. And you test. If there is one positive, then you call every 100 back and you test individually. Because the majority were negative, 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 people want time and the Ministry of Health want save money with this approach. There is also paperless recording of through the Open Data Kit application and new tracking system that were created on top of the health information system that was existing. I talk about the GPS on truck drivers, but what is good, as the minister told you, those GPS information were shared among East African communities because a truck comes from Dar es Salaam, cross several countries, and in Burundi. So they can trace the positive, the person who is positive for COVID, every place where he went. And you can go back there and do contact tracing. Next. There was also the way the protocol for testing was done to know what happened in general in the community, to know what happened in hotspots. That's how we have seen that, Rwanda have seen that some border places were at high risk. And also the use of robots, you can see them in the exposition there. But it allowed to recover quickly the economic activities of a country if you manage the testing and the positive people correctly. Next. The other innovation, like in Nigeria, a tool for self-assessment according your health and the exposure you have taken. Those are good of the population, as well as SMS for those who doesn't have access to internet, and as well as the use of Twitter for mobilization. But the drone also were used to collect information on the respect of social distancing in crowd. And community health workers at village level continued their great work, but didn't enter in the home, used their phone to communicate with families to see what happened. Next. In e-health also, in telemedicine, there were innovation. Amplify what was there by allowing some to do consultation e-based, treatment e-based, and in some countries up to the delivery of drugs using internet and like delivery at home for food or whatever. This can be done only if you have people educated for that, and it can be done only if you have the legal framework to protect the patient and to protect the service provider. Information, I have talked about that, but I want to talk about one example in South Africa, where they create a WhatsApp chat where you can ask any question about COVID in 5 languages. It was so useful because 6 million people used it and were happy with that. It was so useful that WHO took the innovation, and now it's available in 15 languages and can reach 2 billion people. Next. Other innovation in procurement, we have the COVAX, that was an international mechanism to procure vaccine, and was supposed to procure vaccine for 20% of all the country in the world. It was a good initiative, but it failed its goal just because some countries bypass it and stock the vaccine in place to give it to the mechanism. There is also what CDC Africa did through the Africa Medical Supply Platform and the Africa Vaccine Acquisition Task Team that has helped Africa to get more equipment, because countries were procuring, put the procurement together. Now you have an economic say to the farm. If not, you procure too little and they neglect you. Next. You have now the manufacturing of a vaccine that is going. You know that Rwanda is going, not for COVID, but for malaria. Just because what has happened with COVID and the mRNA vaccine is a tool that can be used for other diseases that were there. We have also a legal framework that exists in Africa now. We have an African medical agency that has been recognized by African Union, and it's in process to be ratified country by country. So we are going to have an FDA at continental level that will help validate what we do in countries so that we can sell it with more security. Next. We have innovation in monitoring, app done by young Africans. There are some in Rwanda, there are other in other countries, like Sierra Leone did one that has allowed essential business to resume with safety. And there is also app that had to follow people in quarantine and make sure that the population was protected. In Rwanda, it happened also. We use also phone to call people at home to see how they are, and community health workers that control and help people to be quarantined at home when needed, and see to transfer them in a COVID center when they were when they needed. Next. That I talk about it for the example of Peru to support community against gender-based violence. But I just want to say that if we can make e-justice with good app and with protection, that mean a lot, especially in countries where you have too little number of judges, and those are examples that we can follow for justice, but for other fields as well. Next. Here, I talk to you about the role of head of village to identify those who are Ubudehe 1. And in a country where we have a high percentage of people living in informal sector, they need to work today to eat tomorrow. So if we want them to respect the lockdown, we need to make sure that they have a meal for the family members every day on the table, and only the head of the village can guarantee that. And Rwanda created a system that allowed that. And also solidarity. You remember here in May 20, the government gave their salary, 1 month's salary to start a solidarity fund. And many of us has continued and did that. So it's a matter of everybody If those who are too poor to follow the lockdown regulation cannot, nobody is safe in the country. And having system and innovate to make it happen is crucial. Next. So we can do even more innovation in Africa. Internet user in 10 years has increased by 24%. Mobile subscription, almost more than double. From 316 million, we are 796 million. So when the use of those tools increase, private sector and researchers can have more innovation to propose. Next. So those are innovations from other continents that we can use, especially in education. But it's just an example. It can be done in other sectors. And what I propose is that each and every one, because there come a lot of literature on the subject, in your sector to see what has been done in other countries that can be adapted in where you are living. Next. So the role of education is important because it's our role. Innovation comes because you are curious. You have a problem. You have an idea. You want to test. You are going to fail 10 times. The 11th times, you are going to have a success. We need to create a system, and that's how what the National Council of Science and Technology is doing is great. We need to create a system that encourages you to do innovation and research, that allow you to dedicate time. And for this, start kindergarten. We have to push children to be curious, to ask questions, and to go because the idea that will save the world tomorrow, you and me, we don't know what it is. It will come by somebody who is very curious and will have an idea like that. If we create the environment to do that, it's great. And this is one of the greatest innovations that we can have. And I want to say that our university has been recognized by UNESCO as a solution for low and mid-income countries in the way we work, but all our students have education in pandemic preparedness, One Health, implementation science, because those are the key where we base. And to assure that finance is not a barrier to join us, medical education is for free at one condition. You sign with the Ministry of Health and with UJG that you will work for all your salary during 6 to 9 years for the ministry where you are needed. So we transform the education we give in clinical service delivery where you are needed. And we know how young people love to be appointed in cities, but there they will be appointed where Rwanda needs them. Not only Rwanda, because we have students from RDC, Burundi, East Africa, and soon from all Africa. So thank you very much. Thank you for your attention.
Thank you so much, Professor Benawaho, for your interesting and comprehensive description of the innovations that have happened since the pandemic started. Now we're going to move on to the paper presentations segment of this session. The subject is public health, COVID-19 management, and social implications. And our first presenter is Ms. Aurore Nishimwe of the University of Rwanda.
Thank you, Chair. Good morning, everyone. My name's Oron Nishimwe. I'm a lecturer at the University of Rwanda, the College of Medicine and Health Sciences, in the School of Public Health and the Department of Health Informatics. Today I'm presenting to you an ongoing project about leveraging artificial intelligence and data science techniques in harmonizing, sharing, accessing, and analyzing COVID-19 data in Rwanda, short-named RISE-DA project. And I'm presenting on behalf of RISE-DA study investigators. Next, please. So I will go through the project background, objectives, and continue with the relevance of the project and novelty, touch a bit on expected result and discussion, and we provide the impact of the project to the society and end up on the conclusion. So the project is based on the fact that there is a vast amount of data that has been collected related to COVID-19 in Rwanda. So this data in different data sets. We mainly have hospital routine data available in health information systems like mainly Open Clinic and Open Numerous that are used in our hospitals. We also have COVID-19 testing centers data. We also have data from tracing of the pandemic and vaccination data. Next. And all these data are crucial to guide public health response, policy formulation, and research. Next. However, these data are still fragmented in different silos and available in different structures and formats, like this illustration shows, like source 1, source 2, and source 3. These are different structure of data. And it is always difficult to use the combined data for improving the understanding of the pandemic and for monitoring its progress or generate evidence for policy formulation and research. Next. So this project aims at leveraging the innovative artificial intelligence and data science techniques to be able to create a scalable framework for gathering, harmonizing, and accessing available COVID-19 data. And this will support the generation or the creation of a common interface for data querying, analysis, and reporting on the top of the data hub. Next. So the project has 5 specific objectives. So the first one was to inventory all existing data related to COVID in Rwanda. And the second one was to create the framework for data harmonization. And the third one was to collect new longitudinal data. Fourth one was to build a common data query interface using available open sources. I will touch on this later. And then the fifth one was to leverage artificial intelligence and data science techniques in analyzing this data and generating evidences. Next. So this project is new and innovative. What is new here is that we have different data sets available, and all these data sets have the data related to COVID in different structures. So what we are doing, we are extracting first this data, and we are transforming this data and harmonizing them into a common data model. And after this, we are transforming them and mapping into a common data model. We will be able to analyze data as a combined data set. Next. So the project work mainly involved the creation of an artificial intelligence-based infrastructure that come up with a scalable framework for gathering, harmonizing, and accessing available COVID-19 data in Rwanda. And this framework also will have a common interface for querying and analysis and reporting this data. So in order to create this AI-based infrastructure, we are looking into using the combination of artificial intelligence techniques and data science techniques. But what is new again is that we are bringing in new longitudinal data that we collected in communities across the whole country. Next. So what we are doing, as I show in this high-level architecture of the project, we are actually harmonizing different data sets into a common data model to be able to generate evidence from all the data available on COVID-19. And we are looking into this evidence to guide the monitoring of the pandemic, to guide or to help us predict outcome of the pandemic, and also generate evidence for policy and research. So next. So what are we doing and how are we doing that? We are harmonizing different data sets. Mainly in Rwanda, in our hospitals, we do have health information systems that are being routinely used. We have what is an open clinic as one data set. We have open MRS as another data set, but also we have the longitudinal data that we collected as a project in communities of Rwanda as another data set, but we also have other data sets like the national COVID-19 data set, the tracing data, and other data sets available on COVID data. And we are using different open source to generate a central hub that combine all these data. And these data sources were availed by a community that is called OHDSI. In full is the Observational Health Data Science and Informatics Partnership. And we are looking into using their tools. We first use the ETL model, and this is the extract transform road that we use to extract and transform the data. And we harmonize and federate this data into a common data model using the OMOP CDM, and this OMOP CDM in full is the Observational Medical Outcome Partnership from the OHDSI community. This is an international community that offers these open source tools. And after mapping these into the OMOP, again, we do use other tools that are open source as well into this OHDSI community. We are looking into LACNE to help us get a node for accessing and querying all this data, and other tools, so that at the end we end up with a common data set, a common data hub, to be able to generate general evidence that are applicable to the whole country. Next. So in more detail, what we are using, so we are harmonizing data from Hospital 1 and Hospital 2, and we are working with 15 hospitals into what we call RISE-DA Centro, which is this data set, data hub we are creating as a project. But we are also matching this data set with national COVID-19 dataset available, and we are also integrating the community survey dataset that we have been collecting as a project. So we are still having some discussion on access right, for example. So who we access this data node that we create as RISE-DA Centro, who we get access to this, how are we going to give permissions, and we are also still looking into other technical needs of the project, do we need to create a separate node, or we can give access to the RISE Data Central? And these are the technical parts of the project we are still working on today. Next. So we are working with 15 health facilities that were randomly sampled. We are working with 2 referral hospitals, 2 regional hospitals, and 8 district hospitals. And those district, regional, and referral are working with Open Clinic and Open MRS as a health information system. But we are also working with 2 health centers, one center, Ntarama Health Center and Remera, but the Remera Health Center has a specific data set, Iwacu Data Hub, and that we are integrating it with our own, the already available data set. And we are also working with the community COVID-19 data set that have been collecting data on COVID along the pandemic since it started. Next. Next, please. So I've been talking of the community survey as a new input of the project as we collect data in the communities. Actually, the community surveys covered the whole country, and we worked with all the 30 districts of Rwanda, considering 214 participants per district, and we were interested in their first their demographics, and then we looked into their face mask use, the hand hygiene, the social distancing behaviors, and the risk situation. We looked into the COVID-19 measures being put in place, but we also touched on the mental health situation of the population and the socio-economic situation, and we also integrated geofencing data. Next, please. So these are the expected results. As I said, it's still an ongoing project, but we are almost at the end. So the expected result, we are first looking into a technical infrastructure that that harmonize the data from different data sets into this OMOP CDM format. And we are using a local Mac Mini computers that are deployed at hospitals as a data node to be able to integrate this data at 15 health facilities. And secondly, we are looking into a central data, a central server that will contain a data catalog of these participating sites, and of course, including the OHDSI tools that were adopted for this particular project. Next. Next. So this is a schematic representation of what we are looking into. So we are considering each hospital as a unique data set or data hub that is going to be integrated with a national data set on COVID-19 to be able to come up with a central database that could be used to generate evidence, and we will be accessing this data through the Arachne tool, open source tool of the OHDSI community. Next. As a brief discussion, the project, to our knowledge, is the first on the continent, African continent, leveraging these artificial intelligence and data science techniques using particularly the OMOP CDM. And this infrastructure is relevant not only to COVID, but also to other pandemics, looking into monitoring, outcome prediction, and terror response planning. Next. In looking at the impact of the project to the society, the project is bringing an innovative monitoring approach of the pandemic using AI and data science techniques. And this is a powerful tool not only to COVID, but for public health and other pandemic diseases. Next. So as we conclude, I already mentioned that the project is the first on the continent using these artificial intelligence techniques to harmonize different data sets, but also the design of and implementation using this OMOP CDM-based federated data help the access to the data needed to better track the pandemic, to predict the burden, and to plan appropriate response. Next. So as we conclude again, the chosen architecture, the OMOP CDM from the HDSI community also help us to collaborate with new partners and to develop our partnership as we work with the OHDSI tool, the open source tools. Next. These are some of the reference I would like next to acknowledge IDLRC Canada and CEDA for funding this project and other partnering institutions that are actively supporting and working on this project. These include the University of Rwanda, the Rwanda Biomedical Center, the University of Ghent, Eden's Health, the African Center of Excellence in Data Science, and the Regional Center of Excellence in Biomedical Engineering and e-health, and the RASID Rwanda. Thank you.
We have about 4 minutes for questions. Yes, could you please stand up?
Are you getting me?
Yes.
Okay, thank you for a nice presentation. Thank you for a nice presentation. I'm Dr. Marcel Rutegwa from the University of Rwanda College of Education. You had a nice presentation, but you just kept talking about data set harmonizing from 15 hospitals. When you say, what is the information contained in this data? Is it different or is it the same?
The information might be similar, but the structure of the data, how they capture the data. For example, I may give an example. One may capture the gender, female, yes, one and another one capturing female as one and male as two, another one capturing female as A and another and male B, or different structure, but also the data are different. There are some that are similar, but there are also additional data depending on the data set, because the tracing data set is different from the vaccination data set, is different from the routine hospital data set that comes with clinical outcomes. So we are looking into harmonizing all these data to be able to predict the outcome of the pandemic and get more evidence about the pandemic.
Okay, so they have different systems and they
Sure.
record for recording the same information.
Recording some similar information and additional information depending on the goal of the data set.
Okay, thank you. Now it's understandable.
We have time for one quick question.
Okay, thank you very much for nice presentation. I'm Wisambi. I want to, first of all, congratulate you with a statement that what you're doing is the first thing to be done in Africa. Now, how do you deal with the missing data in case if they're available? Thank you.
It depends on the objective we are looking into, but we haven't reached the analysis phase so that we have some missing data. But I think when we be having some missing data, we need to integrate and consider the full data set and look into where we have complete data. Fine.
Thank you so much. Our next speaker is Dr. Elamayu of the University of Global Health Equity in Rwanda.
Thank you so much, Matt. My name is Alamayo Ambarbar. I'm a medical epidemiologist and a research faculty at the University of Global Health Equity. The topic of my talk will be monitoring the impact of COVID-19 pandemic on essential health service in Rwanda. Next, please. So this is the outline of the presentation. I'll briefly touch on COVID-19 in Rwanda, implementation research in exemplars for under 5 mortality. I will talk about it a little bit, methods, results, and conclusions. Next slide, please. Next slide. So as a way of background, globally there has been a disruption of essential health services during the period of COVID, and according to the World Health Organization survey, 94, thank you. Can you go back, please? 94% of the 135 countries and territories included in that WHO Pulse survey reported disruption of one or more essential health services, and then some of the services include disruption of reproductive, maternal, newborn, child, and adolescent health, also involving immunization, communicable disease, NTDs, as well as disruption of non-communicable diseases. Next slide, please. So after the first case of COVID reported in March 2020 in Rwanda, Rwanda implemented swiftly some of the evidence-based intervention that include rapid enforcements of known COVID-19 interventions, like in mask wearing, social distancing, etc. Infection prevention and control of IPC practices, like in separate COVID-19 treatment centers, training of health workers on IPCs, equitable approach to COVID-19 response, including free testing, welfare support, etc., and then adoption of technology, as a previous speaker alluded to, including surveillance system, robotics for temperature checks, etc. Next slide, please. So study objective is to understand if and how health system delivered evidence-based intervention, like immunization, facility delivery, antenatal care, targeting amenable under 5 mortality were maintained during the period of COVID. We looked at strategies used to identify, prevent, or respond to these evidence-based intervention drops, for example, data use, stakeholder engagement. And we also looked at factors that helped or hindered this response, including health system and leadership. And then we also looked at to see how the previous efforts to implement some of these evidence-based intervention in Rwanda supported the maintenance of this intervention during the period of COVID. Next slide, please. So we conducted an implementation research, and just to spend briefly, so we conduct research to produce evidence-based intervention, for example, efficacy as vaccine or integrated maternal and child health intervention, and then we have a practice to ensure that that reaches to the community or individual benefit in order to reduce under 5 mortality in this case, or days. So basically, Nick, can you click? So what implementation research does is it just closes the gap between research and the practice. It evaluates implementation strategies to help integrate this evidence-based intervention into real-life world setting to produce patient impact or the public at large, for example, in terms of the reduction of under 5 mortality and days. Next slide, please. So our overall approach, so we build this work on our previous work on under 5 mortality exemplars work. This is exemplars work that were conducted previously couple of years ago, including a couple of exemplars countries in global health, including Rwanda, Ethiopia, Senegal, Nepal, Peru, Bangladesh, looking at how and why these countries outperformed in terms of the reduction of under 5 mortality between 2000 and 2015 as compared to their regional peers. And we utilized an implementation research framework. This basically encompasses a number of parameters, like starting from exploring, we call it EPS model, or exploration, preparation, actual implementation, adoption, and sustainment. If you take an example of, for example, COVID vaccine, so there is a preparation and exploratory phase to adopt this intervention, and there is also a preparation based on data, and then the actual implementation to reach the intended target, and then adoption of some of the strategies as well as sustainment mechanisms. And then this interplays with other external factors either at a national level or global level, including funding and etc. Next slide. So we utilize 3 data sources. One is a desk review. We reviewed various peer-reviewed articles from PubMed and other data sources. We also reviewed multi-country case study reports from the WHO, such as Global Fund and Global Financing Facility dataset. And we also reviewed some in-country dataset, like in publication from the Rwandan Ministry of Health, as well as the Rwandan Biomedical Center. Next slide. And then second data set is from key informant interviews. A total of 21 key informant interviews were included in the study. Key informants selected represent all stakeholders within the health system. We tried to be as representative as possible from Ministry of Health, RBC, professional association, implementing partner donor, as well as representation from a private sector. Interviews were completed virtually, and the interview guides were designed to assess a number of strategies, some of the contextual factors, as well as some of the existing challenges. Next slide, please. We utilized a mixed methods approach. So the third data set is a quantitative analysis. We used the Rwandan Integrated Health Management Information System, the HMIS routine admin data. And we plotted a scatter plot using interrupted time series analysis. And just to clarify the time frame, we called the time frame from January 2017 to February 2020 as a pre-COVID, and then from March 2020 to December 2020 as a COVID period. And then we used a Poisson regression model to estimate the impact of COVID-19 on HMIS indicators. And for a qualitative analysis of key informants, we utilized interviews were transcribed, translated. We used a Deduce software for iterative coding, and we applied a thematic analysis of coded interviews. Next slide, please. So coming to some of the findings, so the first one is in relation to vaccination, doses of vaccine administered before and after March 2020, the period of COVID. So the y-axis is number of doses administered, the x-axis is the time period, and then the yellow straight line, the vertical line is the one that delineates the period of COVID, March, M is March, and the purple triangle is actually the actual number of doses plotted. So as you can see there, it looks like there is a slight drop in DTP3 as one of an indicator, as well as rotavirus 2 vaccine during the period of COVID, comparing 2019 up to from January 2017 to February 2020, and then that compares to March 2020 to December 2020, both for DPT3 as well as rotavirus 2. It looks like it is maintained very well, apart from a slight drop, and then bounces back again after a few months. And to be precise, from the slight drop from March to end of April, I think that corresponds to the first lockdown, and then number of strategies were implemented, then the service bounced back. Next slide, please. Looks like there is a slight increase in antenatal care force attendance, whereas there is a maintenance of facility delivery during this period. The increase in antenatal care during that period is difficult to explain, but it could be due to the fact that probably more women were at home and they want to seek care for antenatal care, or it could be that there may be some sort of perceived susceptibility by a pregnant woman to seek care both for their own as well as for their children. And it looks like there is some maintenance of facility delivery as well during that period. Except that there is a slight drop of around 5%. Next slide, please. There is a marked drop in DRL cases treated, both at the facility and at the community during that period. As you can see from the graph, there is a marked drop during the period of March to April 2020, whereas results or coverage bounced back again from June to onwards, both the case at the facility as well as the case at the community. Next slide, please. And similar to the diarrheal diseases, there is also a drop in community, in pneumonia cases treated both at the facility and the community during this period, as I mentioned previously. And I think the drop could be associated, this study doesn't specifically explore some of the reason, but it could be associated with either fear of the patient does not to go to the facility, or it could be associated with some reduction in some of these infectious diseases due to school closure or infection prevention measures. But again, this is not the purpose of the study. Next slide, please. So coming to the qualitative findings of the change in essential health services as reported from key informants at a various level, there was a reduction in the following services as reported by our key informants. Those include reduction in a drop in vaccine coverage, OPD consultation, antenatal care visits, facility-based delivery, interruption of gross monitoring, and some missed appointment of NCD patients during that period. And as I mentioned before, some of the key takeaways from the key informants is that some of the causes of reduction include challenge of transportation, I think that's clear, and the community and health workers' fear of COVID-19 during that time, and overburdening shortage of healthcare workers, particularly some of the health workers are moved towards COVID care. And then there could also be some change in disease burden. Next slide, please. So, as this is an implementation research, we looked at some of the implementation strategies that used to prevent or respond to the evidence-based intervention drop. One is the response to COVID-19 that in turn supported the maintenance of this evidence-based intervention like vaccination, facility delivery, antenatal care, etc. And some of these include, for example, provision of PPEs, community-based healthcare delivery, including outreach services, by the community health worker, school visits, gross monitoring, etc. And then data use is another strategy, particularly reviewing frequent data, live data, and ensuring if there is disruption, then there would be some implementation. Mentorship and supervision, and the provision of transport both by the donor as well as the local government. And community engagement, empowerment using different methods, including radio messages, the use of digital platform as one of the strategies, including a use of WhatsApp group by different health workers, enacting a policy environment, ensuring essential health cares are actually critical, and then donor and implementation partner coordination by a Minister of Health, a focus on equity, some level of disaggregate analysis, and then leveraging existing systems, and then the establishment of command posts to ensure logistics are more streamlined. Next slide, please. And then these are some of the facilitating contextual factors identified from the study: the existing collaboration and coordination mechanism, existing structure of collaboration through the National Strategic Plan, community health worker system of learning, Rwanda system of learning and improvement, regular monitoring and evaluation of supported identification of disrupted health services. Data availability, like in the HMIS data, is quite impressive. And the supply chain system, for example, strong supply chain system and adaptability of supply chain system from a pull to a push system. Next slide, please. And then these are some of the challenging contextual factors. As you expect, the lockdown, movement restriction, some level of stockout, community fear, workload, as well as healthcare workers' fear of COVID-19, particularly in the early phase of the epidemic. Next slide, please. So in conclusion, Rwanda maintained most of the evidence-based intervention for the reduction of under 5 mortality during the period of COVID, for example, vaccination, facility delivery, and then some of the drops bounced back after the first few months, particularly after March to end of April. And then lockdown, movement restriction, and fear of COVID by the community were some of the barriers. And then some of the key implementation strategies included community-based healthcare delivery, the data use, mentorship and supervision, provision of transport, community engagement, education, and use of digital platform, and the ability of the Rwandan health system, what we call health system resiliency, to adapt encourages flexible response to fit the situation. Next slide, please. I would like to thank the University of Global Health Equity and Northwestern University team, Professor Bainagaho as a co-BI, and the rest of the Global Health Exemplars team. The study was funded by Gates Venture and the Bill and Melinda Gates Foundation. We are grateful for our key informants who generously provided their time as well as their insights. Thank you very much.
We have about 5 minutes for questions.
Thank you very much for the good presentation. My name is Dr. Sanja from University of Kigali. Back to your presentation, I realized that you've used specifically a key informant that is on data collection. Which other tool of data collection did you use? Question number 2, linking your findings. It's like you've captured some findings which don't trigger to the qualitative. So if anything, you were supposed to have probably put the quantitative data collection tools. Thank you.
Can you repeat your second question? I'm not clear with your second question.
Second question is that the tools which we're collecting, the quantitative, have not properly reflected. Briefly elaborate on the quantitative tools you used. And the first question is touching on the qualitative.
Yeah. Thank you so much. So we utilized a mixed methods approach. The first one is for the key informants. We actually developed the interview guide for using implementation research framework that I alluded to, the hybrid implementation research framework that were previously used in a multi-country study to identify, to explore how and why this global health exemplars country, including Rwanda, outperformed in the reduction of under 5 mortality. So it is actually developed by our own research team, but also some of the questions were previously used. For the quantitative data, we have used the routine data. We used HMI's Health Management Information System data from nationally from the different districts, and we analyzed those data using interrupted time series analysis. So some of the indicators include, for example, vaccination for a different vaccines, DTP or rotavirus, measles, etc., and the fast delivery by months, and antenatal care, as well as some of the morbidities from diarrheal disease, pneumonia, both reported at the facility as well as at the community, as reported, as available from the Health Management Information System data.
Thank you for the great presentation. My question is related to the community health worker. You did mention that the dropout in, for example, the number of people being treated for some diseases on the community level could be due to a lack of community health workers. And my understanding of how this health workers are selected. They are kind of nominated on a local level, for example, in every sector or something like that. So my question is, when you say there was at some point a lack of community health workers, what happened in between? Did some move away from the position? Do they not get replaced? So why would there be a shortage at some point? Thank you.
Thank you so much. So generally, there is a drop in treatment-seeking behavior, both for diarrheal disease as well as for pneumonia, respiratory disease, at the facility as well as at the community level. We haven't investigated in depth the reasons for the drop, because that's not the purpose of the study. But we hypothesize that it could be because of two things. One, there is a general reduction in health-seeking behavior. For example, due to, particularly in the first few months of the epidemic, there is a lot of misinformation, there is a lot of panic, so there is a fear of health community as well as patients not going to the facility or at the community health worker. Two, it could be a real reduction of some of these infectious diseases due to, for example, school closures or due to some of the infection preventive measures. The other one is a shortage of healthcare workers. It's not specifically for community health workers, but generally there was a shortage of healthcare workers because some of their healthcare workers are pulled towards the COVID isolation centers. Thank you.
Thank you very much, Dr. Ryan. So our next speaker is Dr. Thierry Habyarimana of INS Ruhengeri, Rwanda. Welcome.
Good morning, everyone. I'm happy to be with you today and present some of our results, preliminary results on oxidative markers for COVID management. So it is one of the studies that have been funded by NCST and under the theme predicting and monitoring the impact of COVID-19 pandemic. So it is a joint study from INS Ruhengeri and our partner at Italy. Next slide, please. So it will be, I will just decline a small background on the study, talking about the relevance of the study in terms of what the innovation we are bringing throughout the project. We talk about a little bit on the objectives and result and discussion, and we decline some impact on the society and draw some conclusion. Next, please. So the experience of 2 years, the last 2 years, have clearly showed that the lockdown and the restriction measures are harmful as well as the disease. So for a country that care about the life of its citizens, could also care about both health and the wealth. So it is like a lose-lose situation where if you care about the health of a small population, you can impact the wealth of the community. But if you care about if you want to preserve the socio-economic activity of the country, you also impact the health of those people who are very sensitive. So such kind of problem should find a very good decision so that you can preserve both the health and the wealth. Next slide, please. So one of the well-known mechanisms of immune cells is to produce the so-called ROS, reactive oxygen species, that cooperate to clear the infections. So however, when there is an imbalance, as you can see on the slide, so when there is an imbalance between antioxidant and the oxidant, you have the damage of vessels, cell membrane, which are damaged, protein and nucleic acid degradation, not only for the pathogen cells infected, but also for the normal cells. So the innovative idea we are bringing throughout this project is to exploit the notion that one can use the early markers of oxidative markers that can be used for early detection of such kind of hyperimmune response. So we are proposing to use the markers of oxidative stress, pro-oxidant, the DROMs, the reactive oxygen metabolite, and antioxidant tests as a plasma antioxidant test. So the capacity of early identifying those markers for the people who have an increased risk of developing the delayed complication of the disease is crucial for clinical handling of the pandemic, but also in perspective of preserving the clinical resources. Next, please. So the general objective of this study was to evaluate the oxidative status as an early markers to a population that can be allowed the adoption of localized or personalized measures to reduce both the clinical and socioeconomic impact of outbreaks. So we are intending to identify the community with high risk of becoming a hotspot of future outbreaks or regions with identified cases of infection. And we are intending to set guidelines to the community health facilities to implement a system of control of those biomarkers. Next, please. So just before talking about the results and discussion, just a little bit on the methodology. So we have screened around 1,300 volunteers who accepted to participate in the study between 18 years and 16 years old. And we have analyzed the redox, both antioxidant markers and the oxidative markers. So our preliminary results are very interesting. First, we have a sharp normal distribution of values, which have indicated that our analysis have a kind of robustness. Then we have also observed a marked difference was observed on the oxidant markers, DROMs, which was higher compared to the population from Europe, or let's say Caucasian population, compared to African populations. So the value was significantly high compared to those populations. And the reason behind is being investigated, which can be due to the differences in terms of nutrition, the exposure to UV, or some genetic variabilities among the population. So we think those individuals with high values of antioxidant and low values of PAT are those who are more exposed to develop the severe form of COVID-19. So those people should be followed. So if we can stratify them, we should not just follow those people and prevent those who are not at high risk to develop the disease. Next slide, please. So we think the results of this study can stratify the population on the basis of their plasma redox in clearing the oxidative stress. And this would constitute an ideal approach to identify and isolate on people or population who are at high risk of developing a severe form of the disease. It will also contribute to the implementation of an efficient system of measure and analysis the biomarkers for oxidative stress as surrogate points to the risk of hyperimmune response in the perspective of an efficient and optimized use of clinical resources and the preservation of socio-economic activities. So next slide, please. So to conclude, these preliminary results give a more systematic analysis and provide an operation basis in the use of those both antioxidant and oxidant markers, DROM and PAT, test to screen or to follow up our patients. So this is particularly important in the context of public health preservation and the optimum allocation of public health resources and preservation of socio-economic activities. So in addition to that, this is, to our best knowledge, the first study to be reported in our region or in Africa, let us say, and we think they can be used for not only COVID, but also for the other infection that can, for future outbreaks that can, could have the same natural history of like COVID. Next, please. Next. So we thank the NCST, which funded the project, and both institutions, Ines Ruhengeri and the University of Parma, but also the whole team of Ines Ruhengeri who participated in the study, the team from University of Parma, Professor who is following us online, I hope, Professor Constantino and Ms. Chiara, and of course, many thanks to the people who participated in the study. Thanks so much.
We have someone online.
Grazie. It's interesting. I think that's great. I think that's fantastic that you're actually doing these types of studies here. I think that's really important in a global setting. Specifically, the question I have is the highest risk group of people are over the age of 65. Your inclusion criteria was less than 65. Do you care to comment?
So, yeah, you are right. We have just included we have taken people between 18 and 65 because we have considered already people above 65 have already high ROS. Already they have such kind of, they are already exposed to the high content of oxidant markers. So we just included those people who have already been defined by WHO as high risk. They have been excluded, people above 65. We can say, but obviously among our people, only one person had 58. So we were in the range, let us say. Yes, please.
Thank you so much. I agree this is a very interesting study. Also following up the previous question, have you excluded comorbid condition like diabetes, hypertension, or chronic obstructive pulmonary disease? Or you have stratified some of these oxidative markers by this condition?
Yes, thank you so much for the question. So at the beginning, but I didn't talk about it, at the beginning we have, it was 2-phase studies. So at the beginning we have selected almost 100 people without any comorbidities. We have tested people with COVID negative, without diabetes, hypertension. Those comorbidities have been excluded. Then we have screened people without considering those. So the first objective was to define the baseline for Rwandan population. So in the second phase, we are intending also to analyze people who have different form of COVID. Those with, hopefully it will not come back,
But we are intending to also analyze people with COVID with different form of the disease so that we can have conclusive results at the end. Thank you so much.
Oh, thank you very much. Our next speaker is Dr. Yadafashije, INS, Rwanda Faculty of Applied Fundamental Sciences.
Good afternoon. I think for me, because of being a teacher for a long time, I may need a hand microphone. So if possible, I can have it, since standing may sometimes, I'm sorry to ask it. Hand microphone. Thank you very much. My presentation is mathematical approach for strengthening COVID-19 in Rwanda. Before presenting, I have a story for you in science that I have experienced. If we talk about mathematics, I remember some histories. One is one time we were in a class studying integration. I think for those who did mathematics, they know it. Then the headmaster entered the class and asked one of the students, why do you think integration is important to your life? Do you know what the student said? The student said, no, integration for complicating our minds. That was the response of the student. Another time, we were in ordinary level, and there was a simple equation of x plus 5 equal to 0. And one student was asked to respond to the question. Then he went on the board. He said, now x plus 5 equal to 0. So now the response is already there. Those are some stories I remember in mathematics. Another one was in chemistry. I was at Yambugo University. We were in the laboratory. Then when mixing some chemicals, we found fire. Science is always a challenge. And when challenges are there, responses are coming. Thank you very much. That's a short story that I want to share with you in mathematics and science. My presentation is not today. It's a mathematical approach for strengthening COVID-19 in Rwanda. So we sometimes think that mathematics is only for complicating heads. No, this philosophy should go away within young scientists. Since mathematics has a role in epidemiology, we did a lot for managing some infectious diseases. I just want to start on presentation outline. We have project background, relevance and novelty, objectives, result and discussion, importance and conclusion. Next. Today, if we say COVID-19, all of us we understand is actually a public health threat in the world. And as per the report of World Health Organization, it contribute to 1.5 M. But also mathematical models were used for a long time to monitor and control infectious diseases. Next. For the relevance, we designed a model. This model was composed of 5 compartments. One is susceptible population. Another one is infected population. Treated. D stands for death, and the R stands for recovery. Ladies and gentlemen, a lot of calculations were really done that are not really here because of time. We calculated a lot on the contacts between S and I, or infected rate, recovered rate, all of them were conducted. And we used the next matrix generation, matrix for next generation to compute some R. which is basic reproductive rate, but also we used Python for some figures, and also we use Stata to compute the association between diagnosis, mass diagnosis, and the infection rates. Our aim was to determine the transmissibility rate of the pandemic, and to evaluate the relationship between mass diagnosis and the infection rate in population. These were two of our objectives. Next. Next. Speed to results. Come back to methodology, we extracted data from RBC website, and we divided our data in 4 periods containing 5 months each period. One was from May to July 2020. That's the first period we counted. The second period was from August to December 2020. The third was from January to May 2021. And the last one was from June to October 2021. So we really wanted to see whether transmissibility was the same or different. For the first period, as per the graph, you can find how the infection rate increased from first 2 months and reduced from last two months. And what was interesting us was the basic reproductive number. We computed R of 2.9. As you remember, at the beginning of the pandemic, the government declared that the transmissibility rate was 3, which is the one we computed here at the beginning. So going to the second period, next slide. From October to December 2020, we have computed 4.1, showing that the transmissibility was different across periods, because here it becomes 4.1, showing that it was changing by periods. Going to the third period, next slide. Next slide. We have computed a basic reproductive number, which is equal to 8.11. Now this is 2 times. 2 times from the second period. And you can see how the infection rate was from first month to the 5th month. This may due to changes going high and down may depend on some strategies that were taken by the government of Rwanda, including lockdown, even if we did not verify it, but it's a prediction that the pandemic changed like that. So for the 4th period, please, next. For the 4th period, a big challenge because the basic reproductive number was 24.7. That is around 25, which means that from June to October, one person was to transmit infection to 24 or 25 people, which was a big challenge, depending on how the pandemic started, from 3 to 25. Next. We looked at relationship with mass diagnosis and infection rate. We took 2 months randomly. That is April 2020 and May 2020. We find difference depending on how many people were diagnosed for COVID. You can see for April, we realized that there was no relationship with mass diagnosis and infection rate. But when it comes to to May, we found that the probability we found that there was a positive association between mass diagnosis and infection rate, which is something interesting to hear. If we diagnose today and we find a number of infected rate or infection rate, whether it's high or low, it may depend on how many people you've diagnosed, and you can't stop the preventive measures because of low infection. It may depend on how many people that are diagnosed. Next. Impact knowledge on transmissibility rate is a driving factor to the reduction of the pandemic in population, since the government may take some measures based on transmissibility rate. Government also should use these findings to improve diagnosis. Next. Conclusion is that the study revealed the pandemic infection rate increased from first period to fourth, hence the productive number changed from 3 to 25. There was a strong positive association between mass diagnosis and infection rate in population. We recommend mathematical model to be used as tool for diagnosis of infectious diseases. Next. Next are references. Next. We'd like to acknowledge National Council for Science, Technology and Partners, and also Ministry of Health and Biomedical, Rwanda Biomedical Center for Data Availability. Thank you very much for your kind attention. Thank you.
We have time for questions.
We also encourage people online to ask questions.
Yes. Yeah, thank you so much for this nice presentation. It is just a question of curiosity. I would like to understand a little bit more the rationale behind the choice of the 4 periods. Why not 2 periods? Why not 3 periods? Why not a period of 3 months? Why not a period of 7 months? What is the rationale behind this? And the next question is about this model. I am curious to know if it can be applicable to other cases or other diseases that we know.
Thank you very much, Prof, for your great question. These periods were taken randomly. However, we wanted at least to see whether there is variability of basic reproductive number, so that we be sure for the frequency of the pandemic. Because now 2 periods were not enough to generate the conclusion. For your second question is that the application of the model for other diseases, yes, is possible. Because we even recommended saying that in the future pandemic or the infectious diseases, the model can be applicable. This is because the compartment that we considered can be applied to other diseases, since no disease can fail to have death rate, susceptibility, or recovered individuals. So all of them are there, it can be applied. Thank you very much for your good question.
Chair, I think you have accepted my question.
Yes.
Okay, thank you very much. My question, you were showing how the basic reproduction number was doubling and then times 3, times 4. And you mentioned about the model. So first of all, I would like to see the model. The model, is it, what kind of the model is? Is it ordinary differential equation model? Is it stochastic differential equation model? Is it partial differential equation modeling? And then I would also know how you computed the basic reproduction number R0, R0. So what formula are you using? Is it, is it an assumption or? So just those 2 questions about the model and then the computation of R naught. Thank you very much.
Thank you very much for the last question. For computation of R naught, we have used matrix for next generation to generate R naught. That's one. Two, this is partial differential equation model, because we computed using differential equations. So this is partial differential equation model. That's why I apologize at the beginning that we did not bring all calculations that we did since really much. But if you're interested, I can share with what we did before the paper before publishing the paper. Anyone who wants it, we can really share what we did, and we're really relevant. Thank you very much for the question.
One more question?
So thank you for your presentation. I have a small question about the graphs. Maybe you can show one of them. You have plotted the period with respect to infected cases. So it seems as though the infected cases have reached 1 million. Am I right? And the reason behind that?
Can we go there? I don't think it reached there, if I can see the graph. Which graph? Is it graph 2? To 4. Please go there. Okay, yes. For this, we predicted based on the basic reproductive number. If the pandemic continue, how will it be? Not really reach it there, but if there are no control measures, the pandemic may go even to more 1 million. That's what we wanted to show within the graph.
Very much.
Thank you very much.
Our last speaker for this session is Dr. Yangabo, PhD Research Policy, University of Rwanda, CAVM. Welcome. Thank you.
Thank you. Okay. All right. Thank you. I'm Parfait Yongabo. While I'm waiting that they upload the presentation, I can just, well, now we are there. Yeah, I'm Parfait Yongabo. I'm a lecturer at the University of Rwanda, and I'm also the program impact lead for the MasterCard Foundation Scholars Program at UR. I'm going to share with you some learnings from our study on COVID and the science system in Africa, where we looked at how the COVID has informed science system to rethink on how the science or research organization can be organized much better to respond to the society challenges. This was a study that we did in collaboration with the University College London team, where we had Julius, Carla, Remy, and Fernando as our collaborators, together with I and Anne-Marie from the University of Rwanda. Next, please. Yeah, my presentation is just organized where I will give a bit of the research context. I will talk on the objectives and also give highlights on the rationales and the methodology that we used for this study, and also give some highlights on the research findings, the discussion and the policy and the practice implications of our research, and also some conclusions that we drew from our study, and some key references that people can maybe look at for some more information, as well as the acknowledgement. Yeah, as I said, this is a collaborative research which we conducted under our team, the UR and the UCR team under the Innovation Ecosystem Lab, which is our platform where we interact to explore different factors that might drive the organization of science to respond to the societal challenge. So we look at the technical, economic, social, and the political and the institutional factors, how they emerge and how they interact to influence the science, technology, and innovation system, particularly in developing countries, because we know that the way science systems and innovation systems respond depend on the contextual realities. So for us, we focus on developing countries' realities. And we use our platform always as a space for dialogue, for mentorship, and also for research operationalization and collaboration. Next. Yeah, as I'm giving the background and our platform, so far in the last 3 years, we have implemented a number of projects that are looking at how science granting councils are building their capacity to in terms of funding, in terms of research management, in terms of monitoring and evaluation of research, how research instruments are being framed. So we first looked at how the Science Granting Council initiative has trained the science granting councils to build their capacity in those areas. That was under the STEX project. And when COVID kicked, then we had the follow-up study on now to see how those capacities that the science granting councils have built have enabled them to contribute to responding to the COVID-19, where different response mechanisms were being put in place. So we looked how the science granting council leveraged on the capacity that they got from different sets of the trainings from the science granting council initiative to contribute to shaping the response to COVID-19. Next, please. Yeah, now we have an ongoing project on the Science Granting Council initiative, political economy analysis, where we look at, we aim to inform the Science Granting Council programming by doing a nuanced analysis of research and innovation ecosystem at national, regional, and international level, looking at key regions, the East African region, the West African region, and the South African regions. And on this, we are collaborating as well with the University of Johannesburg, plus UR and UCL. Next, please. Yeah, coming back to the objective of this study, as I highlighted, this study stems from the STEC Plus project, where we looked at how they gained the capacity of the Science Granting Council, enabled them to contribute to responding to the COVID-19 pandemics. So our research questions was has the science, technology, and innovation capacities in the councils enabled them to act swiftly, more decisively, and timely to the COVID-19 pandemic. And we departed from the hypothesis that the COVID-19 pressure has stimulated the councils to rethink on how science systems are configured and how the instruments are formulated, and the relevance and the agility of acting on time and effectively. Next, please. Yeah, we used the STEC Plus conceptual framework, which was inspired by the overall National Innovation System framework, where we look at the structure of the system and the functions and the interactions. We look now at the factors, the exogenous factors from the COVID-19 that we are pressing the science granting councils to take actions, and the point of actions that the science granting councils were expected or decided to take, and then how they set up the mechanism for responses and how they deployed the responses and the adjustments that were made in the process, and also the outcome of the responses or the contribution that the science council, granting councils have made into responding to the COVID-19 pandemic. Next, please. Yeah, we did our study in 9 countries, Burkina Faso, Kenya, Malawi, Mozambique, Namibia, Rwanda, Senegal, Uganda, and Zambia. So we used both desk research and the questionnaire semi-structured interview, where we did the purposive sampling in the science granting councils, the collaborative technical agencies, and the Science Granting Council Initiative management team. We had the 25 interviews to get the expert views and the perspective on how the science granting councils have been contributing to COVID-19 response mechanisms. We did a thematic analysis around the key themes. One was the nature of the contribution in the COVID-19 response mechanism. The second was the funding of research funding. The other one was the collaboration, and the other one was the needed capacities that the Science Granting Council didn't get from the training that they had earlier. And then looking at now, maybe the future perspective that they will take. Next. Yeah, as part of our findings, we realized that through the training, the members of the councils acquired skills in research management that helped them when the pandemic kicked off, because we all realized that all the actions that were needed to be taken were supposed to be informed by science and by research. And as we could see from the previous presenters, we had a number of different studies that emerged because COVID was there. So then the science granting councils, in different case studies, some of them were directly involved in identifying the research interventions that were to be done. And others were intervening in the periphery, not really being in the response task forces, but advising or providing the key ideas on how interventions could be arranged. Another contribution was about the research funding. So the science granting councils were involved in funding mechanisms by advocating or mobilizing resources for research funding, by lobbying from different funders, including the government or different international collaborators that were willing to fund or that has been collaborating in research funding. And also they were involved in issuing and managing and evaluating calls for research proposals in order to be able to make sure that research that are being to be conducted will be responsive to the challenges that might help to cope with COVID-19. And also they were involved in soliciting the external funding. We will see that in many cases we found different research funding being mobilized from collaborators like IDRC, like CIDA, like DFID, different funding bodies. Next, please. Yes, as I initiated, we looked also at the collaboration. So COVID also stimulated some collaboration, either among the science granting councils themselves, but also among the national system, innovation system actors, where we realized the high interest in academia, industry collaboration, but also the public and the private sector collaboration in different initiatives. We also realized that the science granting councils were also able to influence the national responses, either through the task forces, as I said, but also through providing advice and evidence to inform the decision that were being made. Next. Specifically for the Rwandan case, we learned that the National Council for Science and Technology was involved in feeding ideas to the COVID response task force, providing evidence and advice in decision-making and action-taking. We also realized that the National Commission for Science and Technology in Rwanda was involved in research funding, in mobilizing resources, and the lobbying from the government, where we have one specific call that was targeting COVID responses that was funded by the government, but also through the partnership and the collaboration with other science granting councils. The National Commission for Science and Technology in Rwanda was involved in the COVID-19 Africa Rapid Grant Fund with the South African National Research Foundation. Next, please. Next, please. Yeah. Then having learned all of that, we realized that even though there were some contributions, but some challenge prevail, where we realized that the adequacy, relevance, timeliness, and trust of tools that were employed and the resources that were available, decisions and the capacity remained a challenge, where even though they were willing for contribution, but the resources were not enough. So there were inadequate of resources, but also the time, because, for example, we realized that for some granting councils that the time for review took long, and to some extent they could get the whole reviewers on time because of the limited human capital in some of the granting councils. But we also realized that we have been, in many cases, particularly in the context of developing countries, relying on external resources in terms of human capital and funding. And during COVID, most of the things were stopped. So then we realized that we need to come back home and do everything at our own. And that revealed the importance that we should be relying on internal capacities, but also trusting our human capital that we have and rationalize on the existing resources. Next, please. Yes, we also realize that there is importance of keep mobilizing the functional capacity in the systems, but also having the avenue for interaction among the actors and have synergy and the coordination among the system actors to be able to responsive. And also we need the institutional entrepreneurship to have new ways of doing things effectively and timely. Next, please. As we conclude, we realize that it can't be science as usual beyond COVID. We need to rethink, to reconfigure, and to retool what we have been doing, the ways we have been doing things, the funding instrument that we have been deploying. Maybe should you consider that we should be taking things for granted. We should be agile and adaptive, because when COVID showed us that anything might happen, and we should be resilient and have the adaptive capacity to cope with any situation, either by under stress, but also considering the resource scarcity and how we can effectively and efficiently react to any societal challenges. And we should also consider that they enhance the connection between science, technology, and society. But we should keep in mind how we go about those, and if those solutions are really feasible or quick enough or sustainable, or if that's what we want, if that's the collective will that we have, or if that's the institutional aspiration that we have. Next, please. Here are some key references that people can go for and look for some more information. Next, please. We would also want to acknowledge the conference organizers for giving us the platform to share our findings, the colleagues and the leadership of the University of Rwanda and UCL, the respondent to the study, the stakeholders, and also the Science Granting Council Initiative funding partners. Thank you.
Thank you so much. My name is Dr. Falawi. Can you please expatiate more on the tool you use in analyzing your data? And two, how did you link science system and COVID-19 together? At least I want you to please expatiate a little bit. Thank you.
Thank you. As I said, we did a thematic analysis from the interviews that we did, and the information collected is in the form of expert views, and the perspectives were organized around the themes that were predefined. And we could look at how the science granting councils have been contributing to the COVID-19 responses, where the science granting councils could profile, for example, their roles in either in task forces or mechanisms. Then from there, we could see their level of involvement, if they were at the central task force or if they were acting at the periphery. We also looked at the funding mechanism and the involvement in funding and the type of instruments that were developed or employed to fund specific research that were addressing the challenge that were connected to COVID-19 responses. And we had also quantitative data where we looked at the research funding that was deployed, the number of proposals that were funded, and in which research disciplines that were funded, and look at the proportions of them and how research funds were allocated in different disciplines. For the second, the linkage between COVID-19 and the science systems. Well, the COVID didn't really affect people from the health perspective only. It went beyond the health sector, where even the policy spheres were affected, and other policy configurations, and the science system are part of those other configurations. And as I said, COVID taught us that everything, to some extent, was to be informed by science, and the science systems are the one to coordinate and make sure that responsive science-informed evidence are provided. And being able to do that, you need the science system that are responsive, dynamic, and accommodative. And the fact that COVID was happening in the society, and the science systems are to connect science and society. So that's how the science systems were among the key framework as well to be considered in the COVID response. Thank you.
Okay, I'm sorry, that's the final question.
Okay.
My apologies. If you want to, you can talk during lunch or while we're outside. That concludes the session 2 paper discussions. Thank you to all of our speakers.
Okay, thank you.
As I said, if you have further questions, you can speak to them outside.
Okay, thank you, Matt, for moderating this session. We are now time for the break. As you know, we have delayed a lot. Sorry if you had a question and you didn't get a chance to ask, but the speakers and paper presenters are still here. So we have to cut this short, and we apologize for that, sorry. So we are going for lunch. If you go outside, you are going to see people who are going to direct you. We have only 55 minutes. So let's do our lunch quickly and then come back, because in this afternoon, we are having people, the keynote speakers who are USA and Canada, and we have already gave them the time. So it's better to keep the time for them. And you are going to realize that this afternoon session are going to be like presentation for people who are online. So as they give us the time, let's like keep the time. If we are physical, it's okay, we can be flexible. But those who are online, please let us be like, keep the time. So, bon appetit. Mike here. Hello, guys. Let's keep time. Hello.
and we're taking the opportunity to meet and greet and catch up on things. And I think that's great. That's really one of the reasons we have these conferences, to make those connections and things. So, however, we're here for the conference, and we'd like to just transition now to the next session. My name is Tim Brown. I'm the Director of Research at Carnegie Mellon University, and I'm here to host this next session. So if we can come in and find our seats, we can get started with the first talk. So it's good to see everybody's getting settled. So our first talk is a data visualization approach to mitigate the impacts of the COVID-19 pandemic. And this will be presented by Kofi Isaac from Carnegie Mellon University. So if we can bring him in, then we can get that started.
COVID-19 pandemic. And I have been working on this project with my co-authors.
Kofi, just one moment. We don't have your image yet. Can we get the image of the speaker, please? Either their slides or the speaker themselves. Thank you for waiting one moment.
Okay, is this okay?
We still don't have the slides, so just I'll let you know when we have it. Okay, yes, now we see a slide that says co-authors. Maybe you can go back to the first slide. There you go. So great. Kofi, please go ahead, and you have 15 minutes, and then we'll have 5 minutes for questions. Please start.
Okay. All right. So my presentation will be on data visualization approach to mitigate the impact of the global COVID-19 pandemic. And these are my co-authors. I've enlisted their names here. And this will also be the outline of my presentation. I'll first talk about the background of the project, the relevance, and also the aims and objectives. The second part of this presentation will be about the results, which is basically going to be the dashboard slideshow, and I'll finally conclude. So ever since the World Health Organization declared COVID-19 as a global pandemic somewhere in March 2020, researchers and scientists have been trying to find ways to mitigate the impact of the SARS-CoV-2 virus, with the notable ones being the rollout of COVID vaccines. And in addition to this one, scientists and innovators have been exploring how predictive algorithms and visualization tools could be used to equip stakeholders with data-driven insight and decision-making. So it is based on the latter that we build our project on, with our research question being, how can we equip governments and stakeholders with tools that can accompany them in their effort to mitigate the impact of COVID-19? So just to give you some relevance of our study, and if you are familiar with the COVID-19 space, you realize that there are only a few institutions that are innovating in this particular space. I'm talking about our World in Data, Johns Hopkins, Weathermeter, the World Health Organization, and other few CDCs that are tracking the COVID-19. And truly, if you look at the information about Africa, you will find it on platforms whose contextual focus is really on advanced countries. Stated differently, it's hard to find information about Africa that gives you a better way to actually visualize what is happening on the continent. So with our contribution, we hope to provide stakeholders with a tool, a platform, with which they can view and interact with COVID-related information in a platform that focuses primarily on African countries. And with that said, they'll be able to compare the situation between a country and then the other, and more so at the regional level. Our aim really is to first examine the existing COVID monitoring platforms and build upon them by using interactive visualization tools. And by so doing, we hope to leverage existing public and private data sets the goal, which is to help governments and healthcare practitioners and individuals to augment their decision-making policies on COVID-19. So to be able to achieve this goal, we had to break them down into something we call methodology. So we first conducted extensive review of the literature where we analyzed more than 10 existing COVID dashboards just to understand what has been done, what could be improved on, while also assessing their strengths and weaknesses. So after the review of the literature, we also had to fight with collecting or gathering data, where in this case, we leverage on Oxford University's award in data team. So we're able to get some good number of COVID data sets from their platform. And we also do understand that data from online sources may not be quite reliable. So we built an internal data quality pipeline where we clean and imputed any inconsistent or erroneous data sets in the data sets. And we also created new indicators and transformed the one that really matters in our current setting. And finally, we leverage on web technologies to build the dashboard. So the remaining section of this particular presentation is going to be a walkthrough or a slideshow of the dashboard.
Coffee, we're not able to hear the slideshow.
No, okay.
Maybe you can talk over it.
Just a minute.
You can maybe start again and narrate it yourself.
Okay, sure. Okay. I hope you can hear me now. Hello? Hello?
I can hear you speaking directly, but not the slides.
Okay, okay. All right. So, this is the dashboard posted on pandemic.heroku.com. I'll put the link after the presentation. So on this dashboard, we get to see the indicators that are being tracked. So we have cases, we have testing, we have vaccination, deaths, and also insights. And as of March 29th, that's like last Tuesday, Africa has vaccinated close to 110 million of its population. Africa has also conducted close to 60 million testing, out of which I think 11.4 turned out to be positive cases, and with just 250,000 deaths. One thing we also add to this dashboard is something we call data stories. We realized that it would not be good to just show charts and figures, so we augment it with text that tries to provide some more context to the metric being displayed. So here we have the top 10 countries with the highest infection as of last Tuesday. And you can see countries such as Seychelles, Mauritius, Botswana being ranked according to the first 10. We also do the same for vaccination, and you can see countries doing well in vaccination, Seychelles, Mauritius, Rwanda, Morocco, and a few countries. One other thing we show here on this very dashboard is the bigger overview. Here you get to see all the different waves that are happening across the different continents. So on this very cancerous plot, we see 4 peaks corresponding to the 4 waves that we've had in Africa. So I will now delve deeper into each of the pages to see what is really happening there. So if we go to the cases page, for instance, you get to see a lot more information related to COVID cases. Sorry. So we have daily confirmed cases, the active cases, and also the total cases, showing it in cumulative and also in daily. If you could take a look at this page, we've segmented it into 2 columns, the left being for other countries, with the right being for Rwanda, where we are focusing this research on. So we get to compare Rwanda with other countries just by selecting the country of your choice. Here, I'm going to compare COVID cases between Rwanda and a country, say, Kenya. And you see that as of March 29th, these are the COVID cases reported with their total cases. So you could also toggle around. If the text is becoming too much for you, you can toggle around it just so you can zoom in into the charts. So here you get to see the cumulative cases over time as well as the average cases. And if you are more statistician, you could also see how the cases compare on the logarithmic scale rather than looking at it on the linear scale. So we display a few more metrics on this particular page. But because of time, I would rush to other pages such as vaccination. I think that's where the focus really is currently. So on the vaccination page, we do the same structure, 2 columns, Rwanda on the right, and then other countries on the left. So here we talk about the data stories again, how the vaccine came about, the first country, and then the facility. We also try to give some proportion relative to the population. Rwanda has vaccinated about 67 million of the population. I think they've received first dose, and only I think 60% who also receiving the second dose. One thing we also add on these very pages, COVID active. We try to see how the first dose compares with the second dose, and we show it in the nice time series chart. I will now jump straight into this very page, where we give people the ability to actually visualize variable data of interest to them. So rather than the statistics we saw earlier on, people can actually select different variables and even compare it amongst countries. So on this very page, we get to see how different countries in East Africa have been performing over time. So we have Burundi, Congo, Kenya, and Rwanda. And on this very chart, you see Kenya has been recording the highest cumulative cases, probably because of their population. You can actually zoom in into a particular country by lowering down the time series chart and just compare a few. One thing we also do is to focus more at the regional level. So with this, I can unselect the countries or just focus on the regions. So I want to compare the situation between or amongst countries in Northern Africa, Southern Africa, Western Africa, and also Central Africa, and then see which region is having the highest number of COVID cases. So on this very chart, you see that countries such as Southern African countries are having the highest number of cases. The population could be a factor. So to be able to mitigate that, we have another such as cases per million. In that instance, be able to normalize it by the population and see whether the region is actually indeed having the highest reported cases. Besides just a simple chart, we also show a heat map that seeks to give you the intensity of the variable that you are currently focusing on. So here you get to see which countries are doing well. Here you can see Libya is not has been reporting high cases, over time, and also something similar happening in southern part of the continent.
Coffee, could you please finish up, please?
Okay, sure. So we also provide this particular page for people to select, to find a relationship between two variables. So because of time, I will pause this particular presentation and zoom on to the other chart. Okay, so just to conclude, we realized that by creating interactive visualization such as the one I showed, and also leveraging on public data source from awarding data, World Health and other repositories, we could help people to make better data-driven decisions. And as part of this research, we were limited by getting good data among private data source. So we hope that by strengthening the cooperation between government and academia, it will go a long way to making projects such as this successful. And we also want to acknowledge our founder, MasterCard, also awarding data for the data that they provided in their dashboard, and also AmpsChat for making the chat available on their open source projects. And the website is currently on beta testing, so if you do have some time, you could visit our platform and just interact with it and give us feedback before we make it public. Thank you.
Thank you. Can you go back to that previous slide and just leave that up because it has the URL and people could, yeah, great, thank you. Great, are there any questions for Coffee? Yes, please, go ahead.
Hi, Coffee. I'm David. I know this is really great. I really enjoyed that. But I think the real critical thing is the validity of the data. That's, of course, my experience internationally is that the dashboards and the visualization is really helpful, but it really comes down to how valid the data is. And a good example is the number of cases per country, and is it reliable? So could you just expand on that a little bit?
Okay, great. So with this dashboard, we are leveraging on the data collected by Oxford University's awarding data team. So they have people who are actually experts in various countries who get data from governments and they report it on their platform. So we tap directly into the data reported by our awarding data team. One thing we've been doing over the past few months is to try and see if we can get the first-hand data from government through a data sharing agreement. And it's something that we've been working towards. And if you're able to get that data, then I think the quality of the data is greatly assured.
Thank you. Another question?
There is a question in the chat, Kofi. Adding the narrative to justify the numbers on the dashboard is incredible. Great work, Isaac and team. How is the narrative generated? Is the dashboard in the public domain yet?
So currently, we want to gather feedback from people before we make it public. So for this very one, we can access it, yes, but after the beta testing phase, that's when we put it out to the entire public. And also the narrative is something that the team at Same Africa generated. So the data theorists try to, we went to public good or credible sources to gather this data from. Yeah. And we also provide references to search where we got the data from in the data theorists.
One last question. Maybe I have a question. What you were showing was presenting statistics, various analytics of the, various ways of presenting the data. Are you doing any analytics on the data, either prediction or some sort of relationship between the data sets, anything like that?
Yes, so the first part of the project is more of visualization, like just descriptive statistics. I think the other project that I couldn't show is more of diagnostics, trying to establish a relationship between two variables. I think that's where I couldn't show. But the other phase of the project, which my other research associates are working on, is forecasting. Like, so they've been evaluating models and see which one comes out better and how we can actually leverage on these models to make forecasts into the future about the COVID prevalence and other metrics that has concern. So yeah, that's where we're heading towards, adding forecasting capabilities to the report.
Great, thank you, Kofi. Let's give a round of applause. Is going to be speaking about monitoring demographic in Indo-Pakistan comparisons of media-induced stress and mild depression in mid-year 2021 on account of COVID-19. I think we can all sympathize with that topic. It's presented by Ms. Asfar Yumna, and I understand it'll be presented on the screen here.
Hello everyone, my name is Yumna Asfar, student of biochemistry from University of Karachi, Pakistan. My presentation topic is demographic and gender comparison of media-induced stress and depression in the reign of COVID 2021. It is a survey from multiple countries. Do you know that coronavirus are named for their appearance? Corona means crown. The virus outer layers are covered with a spike of proteins that surround them like a crown. In February 2020, the World Health Organization declared COVID-19 a pandemic. Without disputing the need for the lockdown seen around the world, this approach consequences represent further layers of COVID-19 disaster. A range of strategies have been adopted worldwide based on the population structure as well as healthcare infrastructure of each country. One of the problems that have been faced is the delay in the implementation of control measures. A simulation model by Lai Shengjai and Andrew Tretum predicted that if China had implemented control measures a week earlier, 67% of all cases could have been prevented in 2020. If implementation had done at the beginning of January, it would have cut infection rate to 5%. Talking about the global response to COVID-19, the elevated connectivity of Wuhan with other international airports such as Singapore, Japan, and Thailand facilitated the rapid spread to bordering countries. Countries in Europe like Italy, Spain, United Kingdom, and United States delayed implementing containment measures and failed in anticipating the impact of pandemic in their own boundaries. Italy had recorded the highest number of deaths globally. Among the middle-income countries, Iran was the worst hit. The Iranian government was aware of this outbreak quite early, but only little measures were applied to stop it. India declared the victory prematurely, as was done in January 2021, which ultimately caused devastating effect of second wave on Indians. Pakistan, with a unique challenge of highly porous border, is sandwiched between two epicenters of coronavirus. One is China, another one is Iran. Pakistan has a weak health infrastructure. Instead of that, country recently strengthened their preparedness against COVID-19 by policy formulation and implementation of national emergency preparedness, mandatory thermal screening at all point of entries and surveillance, and contact tracing through data collection. COVID-19, the pandemic that brought the world on its knees, as it not only caused decline in economical structure, further disaster layers incorporate more mental health issues, medical problems from augmented stress, and worsened diet. Self-harm, including suicide attempts. Relevance and novelty of the study is that COVID-19, a novel, evolving cause of death, has not only affected the globe economically, but has also left psychological scars on people all over the world. Sudden chaos due to COVID-19 has led to mental health issues like depression, a strong feeling of sadness among people. It is one of the common mental disorders in the world. It can affect anybody, regardless of sex, ethnicity, or socioeconomic standing. The present study was taken up to monitor of such scars existed in populations. Moreover, media-induced stress was also explored. The outbreak of COVID-19 has disrupted the lives of many people across the world. The pandemic has imposed a sense of uncertainty and anxiety as the world was unable to predict or prepare for this crisis. It has caused a tremendous stress level among children, adolescents, and all students in general, primarily due to closure of their schools, distressing events such as seeing or being aware of critically ill members affected with coronavirus would have a detrimental effect on the mental health. Elderly persons were vulnerable to infection and death because of their pre-existing chronic health conditions and age-related immune systems. A study on North American older patients with COVID-19 showed that functional decline was an independent risk factor and a strong predictor of mortality. It is also important to consider the psychological impact of hospital stay in elderly COVID-19 ICU survivors. Discharged alive, which has been associated with cognitive impairment and poor mental health outcomes. During COVID-19 outbreak, frontline healthcare professionals in hospitals are at a significant risk of adverse mental health outcomes as they have been confronted with mounting challenges that have not been faced before. Extreme workloads, shortage of protective equipment, fear of becoming or spread infection to their relatives with witnessing patients' death have resulted in high rate of anxiety, depression, insomnia, distress, and obsessive compulsive disorder. Physical isolation from family members or loved ones during quarantine or hospital stay can produce psychological instability among people infected with COVID-19. The media broadcast was flooded with the information about COVID-19 and its impact. This lead to a question: was media stressful? Objective of the study were to explore whether media was stress-inducing, gender-wise, country-wise, to explore the occurrence of COVID-19 induced depression with respect to countries, to establish association of depression with education and profession. We have conducted the survey by using Zung self-rating depression scale as a tool in the form of online Google, conducted in the language of English and Urdu during mid of 2021. Data was collected between 10 June till 17 August 2021. 467 respondents became the part of the survey. All those who volunteered were included in the survey. Refilling of the form was an exclusion criteria. Data analysis was done using SPSS 20. The present findings show that 76% participants were from Pakistan, 21% belonged to India, and 3% from other countries. Findings from the present study suggest a significant association between gender and media-induced stress. 71.1% participants from the complete data reported that media was stress-inducing. More female, 72.6%, as compared to males, 70% reported that media was stress-inducing. Result of country-based gender comparison of media-induced stress shows that values or percentages significant association by chi-square cross-tabulations at p less than 0.05. Media-induced stress was pronounced in Pakistanis. Findings from the present study suggest a significant association by country-based comparison of COVID-induced depression as evaluated by self-rating Zung depression scale. We have observed high percentage, which is 65.3% of mild depression in Indians. Chi-square based cross tabulations were not significant between level of depression and education. However, participants belonging to secondary level of education suffered from mild depression, that is 59.3%. Chi-square based cross tabulations were not significant between level of depression and profession. However, the highest percentage who actually suffered from mild depression did not mention their profession, while 35.2% were of students suffered from mild depression. Psychological impact of COVID-19 on South Asians. Our results exhibited 37.3% mild depression in complete data, consistent with the studies conducted by South Asian Affiliation for Territorial Participation Nations and China include 23.7%. People were suffering from depression, anxiety, and stress amid COVID-19. An online survey was conducted involving 2,355 subjects at the area of Prasada Institute, Hyderabad in Telangana, India. Outcome from the survey highlighted that people were suffering from mild, moderate, and severe level of depression. Another descriptive and cross-sectional online survey was conducted engaging 400 subjects at Jinnah Sindh Medical University, Karachi, Pakistan, supported our findings by highlighting behavioral reactions to pandemic, fear, distress, and anxiety. Second wave of COVID-19 on affecting mental well-being of Indians. Our findings indicated greater mild depression percentages in Indians as compared to Pakistanis, as we have conducted the survey during the mid of 2021. And at that time, India was facing a devastating second wave. The second wave of COVID 19 had turned more deadly, contaminating more individuals and taking more lives. Other than causing money related and physical issues, it had moreover influenced individuals rationally, making freeze in their minds. The instability around their show and future, coupled with the government commands to remain at homes, is all worsening mental illness. The feeling of being cooped up at home, removed from their adored ones, void of social back and fear about new variants, is increasing mental sickness. The COVID 19 second wave generated many lessons for policy planners and public health authorities. Realized that victory should not be declared prematurely, as was done in January 2021. Role of media in inducing stress during COVID-19. Our results showed that media played a significant role in inducing stress and depression among the community. Stress is the normal physiological response of human being to variable unfavorable situations occurring in life. Those who are unable to control it go through anxiety or phases of depression. Depression can present itself in physical and psychological forms, which vary from person to person. Our result exhibited that females were of the notion 72.9% that media was stress inducing. As interestingly, a study in Belgium found that females were more conscious about media's reporting regarding COVID, and this induces more stress among females.
We can see your slides now, so you can start whenever you're ready.
Okay. Hello everyone, my name is Shimi Gebna Soni Cynthia. I'm a holder of a master's degree in microbiology and presently a research intern at the Military Health Research Center located in Cameroon. I'll be giving a presentation on the diagnostic performance of reverse transcription loop-mediated isothermal amplification, that is ALTILAM, compared to real-time polymerization reaction, RT-PCR, for the molecular diagnosis of SARS-CoV-2. So next, please. Next, please. So the presentation has the following outline. So COVID-19 was first reported in Wuhan, China in December 2019 and subsequently declared a pandemic in January 2020. Next, please. And since then, it has been considered a public health threat. Globally, as of the 21st of March 2022, a total of about 400 million cases has been reported, with about 6 million deaths, and in Africa, a total of about 8 million cases has been reported with approximately 170,000 deaths. The virus responsible for COVID-19 is the SARS-CoV-2. Next, please, which is an unsymmetric spherical-shaped envelope virus with a positive single-stranded RNA. Next, please. Next. So, we all know the gold standard for the diagnosis of SARS-CoV-2 is a real-time polymerization reaction, which requires a long period of time for its realization, expensive equipment and reagents, sophisticated platforms, and highly qualified personnel. Now, with the increasing demand for COVID-19 testing, there is an urgent need for a simple, rapid, and cost-effective test, such as the Altilam test, which reliably detects SARS-CoV-2, especially in resource-limited settings. Next. Several studies have suggested the use of Altilam techniques as an alternative diagnostic method for SARS-CoV-2. However, few studies have been carried out in relation to this topic in Africa, especially here in Cameroon, where these results may vary within its particular setting and environment. Therefore, there is a paucity of information in relation to the diagnostic performance of Altilam for the diagnosis of SARS-CoV-2. In order to carry out this study, we therefore hypothesize that there's no difference in the diagnostic performance of Altilam and RT-PCR for the detection of SARS-CoV-2. We then pose ourselves the following questions. Are the performance characteristics of the Altilam assay for the diagnosis of SARS-CoV-2 reliably high enough to be used as an alternative test to the RT-PCR method? We then set as objective to assess the diagnostic performance of this Altilam in comparison to RT-PCR for the diagnosis of SARS-CoV-2. Specifically, we aim to determine the diagnostic performance of the colorimetric Altilam assay, to determine the diagnostic performance of the fluorimetric Altilam assay, and to compare the colorimetric and the diagnostic performance of the colorimetric and the fluorimetric Altilam assay. Next. So, before going to our results, it's important to note that this study was a cross-sectional study design carried out at the Military Health Research Center here in Yaoundé, Cameroon, for a period of 6 months, whereby 120 nasopharyngeal samples were collected from individuals visiting COVID-19 collection sites for a COVID-19 test after a written consent was obtained from each participant. Also, it's equally important to note that 2 assays were being performed. That is, a real-time PCR assay was being performed, followed by an Altilam assay. This Altilam assay was provided by the Vienna Bio Center located in Vienna, Austria. Next, please. So, results, in terms of our results and discussion, the following results were obtained. On my left side, that is the picture A, we see the colorimetry detection, whereby a purple coloration signifies a negative result and a change in coloration from purple to sky blue signifies a positive result. Now, on the left side, we see on the picture B, we see the fluorescent detection, whereby a gray or a green fluorescent light signifies a positive result. Next, please. So a total of 120 samples were being analyzed by the RT-PCR method. From these 120 samples, 2 were excluded due to run error. Hence, a total of 118 samples were being analyzed by the Altilam method. Next, please. So from these 118 samples being analyzed by this RT-PCR method, 42 tested positive and 76 tested negative. Next. From the 42 samples which tested positive by the RT-PCR assay, 41 equally tested positive by the Altilam assay. Next, giving us a sensitivity of 98% a statistically high sensitivity of 98%, a negative predictive value of 99%. Next, please. And next. Next also. And it's equally important to note that a very good agreement was obtained between both techniques. Next. These results deviated from that of next. Deviated from that of Nella et al. And Baba et al. These different results could be due to the types of samples, difference in types of samples being used, and the difference in the type of LTLAM and LTPCR protocol being used. Also, it could be due to a difference in the visual subjectivity, colorimetric subjectivity. Next. Again, it's equally important to note that at a CT value of less than or equal to 29, a perfect agreement was obtained between both techniques. Next. From this, we can then conclude that the LTLAM colorimetric technique was capable of properly detecting SARS-CoV-2 samples in samples with high viral loads. These results were similar to that of Ederer et al. And deviated from that of Dieter et al. Next. Okay, next slide. Again, from the 76 samples which tested negative by the RT-PCR method, 73 samples were negative by the LTLAM method, giving us a specificity of 96% and a positive predictive value of 93%. Next. This result deviated from that of Natoli et al. Next, please. And that of Baba et al. Next. These results also obtained could be due to the fact that LTLAM has been noted for the production of spurious amplification products and cross-contaminations. Next. Again, from the 42 samples which tested positive by the RT-PCR method, 42 samples equally tested positive by the fluorimetric LTLAM method, giving us a statistically high sensitivity of 100%, a negative predictive value of 100%, and an almost perfect agreement was obtained between both techniques. Next, please. Next. 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 So these results were similar to that of Taki et al. And Kitajama et al. And this result, this high result, could be explained by the fact that fluorescent dyes improves detection and solve the limit of non-primer derived signals. The difference in results with other studies could be due to the type of samples being used and also due to the type of LTLAM and RT-PCR protocols being used. The next slide. Again, at a CT value of less than or equal to 35, which is the optimum CT value for the RT-PCR assay, a perfect agreement was obtained between both techniques. This similarity in results could be due to the fact that both techniques use the same principle, which is fluorescent detection. Next, please. So these results were similar to that of Fowler et al. And deviated from that of Ganaret et al. Next. Furthermore, from the 76 samples which tested negative by the RT-PCR assay, 70 samples tested negative by the LTLAM assay. Hence, a total of 6 false positive samples were being obtained, giving us a specificity of 92% and a positive predictive value of 88%. So these results were similar to that of Jones et al. Next, please. And deviated from that of Fowler et al. Again, this low results could be due to the presence of spurious amplification products and cross-contamination, which has been noted to be common with LAM results. The difference in results with that of other studies could be due to the difference in type of samples used. Like other studies use salivary samples, while in our study, we use nasopharyngeal samples. It could be due to the difference in the type of RT-LAM and RT-PCR protocol being used. Next. In order to compare both techniques, we plotted a receiver operating characteristic curve, whereby the colorimetry LAM assay had an area under the curve of 96%, and the fluorimetry LAM assay had an area under the curve of 93%. Next, please. It's important to note that this study goes a long way to provide information on the possibility of using the LAM assay in resource-limited settings, hence increasing the testing capacity for the COVID-19. It's equally important to note that it will aid health policymakers in establishing proper management strategies for COVID-19, therefore increasing the economic, social, and health growth of the community. Next. In a nutshell, we can deduce that for the colorimetry LAM assay, 96% of those infected with SARS-CoV-2, 98%, sorry, of those infected with SARS-CoV-2 and 96% of those not having COVID-19 could be properly detected by this technique. Also, a very good agreement was observed between this technique and the RT-PCR technique. Moreover, for the fluorimetry LAM assay, a true positive rate of 100% and a true negative rate of 92% were being obtained. An almost perfect agreement was obtained between this technique and the RT-PCR method. In conclusion, the RT-LAM technique, especially the fluorimetric assay, is a rapid and sensitive assay which can serve as an alternative test to the real-time polymerization reaction for the diagnosis of SARS-CoV-2, especially in resource-limited settings. Next. Next are references, followed by acknowledgement. We would like to thank the Catholic University of Central Africa here in Yaoundé, Cameroon. We would like to thank Dr. Julius Wabegai, the head of CRESAR, the Venable Center, Metabiota, Boalab Creed, the University of Cambridge, and all the participants who contributed to the realization of this work. Thanks for your keen attention.
Thank you very much, the presenter, for a good presentation. That is interesting. I have one comment to research question. The way is asked is not really a research question because it is started by R. So research question to be a question that you ask, then you reflect when responding instead of replying by yes. So if you start by saying this, so someone can respond by yes. My question then is, you had a hypothesis. I don't know whether it's comparing the two kinds of diagnosis that you have been presenting. So did you use any statistical test when comparing? So that's one. Any statistical test, any comparative statistical test used? I didn't see. If I followed well your presentation. Thank you very much.
Thank you for your question. Yes. Yes, we would like to precise that we use the R user interface for our statistical analysis, and to compare both tests, we use a McNamara test, whereby a p-value, whereby for tests that were statistically significant, a p-value of less than or equal to 0.05 was being considered.
Okay. Did that answer your question? Did that answer your question? Was that an answer to your question? Okay, good, thank you. Another question? Okay, we're going to go just to, thank you very much, Chimi. That was very interesting, and I look forward to seeing that test more widely available. We're going to change the order slightly on the presentation. The next presentation is Ms. Bawa from the University of Energy and Natural Resources in Ghana, and she's going to present descriptive analysis and insight of COVID-19 on computer science education. So I believe this is another remote presentation.
Right. Good afternoon. My name is Faiza Umar Bawa from the University of Energy and Natural Resources. My co-authors, or the co-authors of this research on descriptive analysis and insights of COVID-19 on computer science education are Isaac Kofi Nti, Samuel Boateng, Vivian Akoto Ajapong, Peter Nimbe, Owusu-Nyaku Boateng of the University of Energy and Natural Resources, and we have Promise Ricardo Agbedanu of the University of Rwanda. The presentation outline is as follows. We have a project background, relevance and novelty of the study, objectives, results and discussion, impact on the society, and conclusions. Education is a very crucial sector in every country and actually plays a very great role in the economy of that country. Hence, with the onset of the pandemic, that is the COVID-19 pandemic, teaching and learning were greatly disrupted globally. And most countries, if not all countries, had a great impact, especially in the educational sector, where schools were forced to shut down and modes of teaching needed to be changed as quickly as possible. So the influence of disruptive changes on higher education has been explored in terms of curricular problems, student accessibility and affordability, students' acceptance of the redesigned teaching methods. How have students accepted the new modes of teaching that has been usually remote and online teaching and learning. According to Rashid and Yadav, the abrupt transition to adapting to and executing online learning has resulted in a lot of teacher overload and stress. It looked so simple to just pick the current face-to-face structures into online, but it resulted in a lot of extra work that needed to be done. So it is very clear that educators must reimagine approaches to curriculum design, electronic content generation, evaluation, and reporting that may have constructed without sufficient preparation and foresight. On relevance and novelty of the study, scholarly works by Gonzalez et al., Lacave and Molina, Rashid and Rizun investigated the pandemic effects on higher education, and most of these studies were actually in areas such as veterinary sciences, nursing, and others. There has been very little study, or no study to the best of our knowledge, when it comes to the true impact of the pandemic on computer science and IT education, where collaborative work is actually very, very critical. The study outcome revealed the need for effective and efficient pedagogical approaches for educational continuity and sanctity in times of pandemic, such as the novel COVID-19. Up, Adding up to the scanty literature in Africa on educational pedagogies during the pandemic field of computing. Aim and objective. The main aim of this research is to use descriptive analysis to determine the impact of the COVID-19 pandemic on computer science education.
Faiza, we have lost the sound on your presentation. Are you there?
Yes, I'm here. But it seemed it was being played from there. I could share my slide and continue from where the recording stopped.
That would be fine, yes.
Okay. All right.
We have the slides here. You can just tell us to advance.
Okay, all right. So on the methodology, we actually, please, are you seeing the slides?
I see the slide methodology.
All right, great. So we had about 4 data sets. From one data set came from the database of COVID cases. And then the other 3 had to do with data that was collected of students' academic performance before the COVID, during the COVID, and then after the COVID. So with the student performance, the data only presented grades as in individual GPAs of courses, but not the cumulative GPAs, which we had to compute on our own for the 3 sets of data sets, and then put all these data together, combining it with the COVID cases, and then performing the analysis on our integrated data. We could move on. Next slide. Yeah, so the descriptive analysis, based on the results, we saw that 44% were computer science and then 56% were from the IT. In terms of male and female, only 10% were female as compared to 90% male. This goes on to still tell us that we have a very low presentation of female when it comes to STEM programs. And then with regards to the male and female distribution, the average age is 23 for the female and then 24 for the male. Next slide, on the COVID data over the period of study. So this graph shows the COVID cases starting from March 2020 to December 2021, and then we clearly see the peak periods of the pandemic. Then on the cumulative grade point, that is the next slide, we identified that the average CGPA of students before COVID was actually between 2 and 2.5. Within the COVID, the GPA, the average GPA actually shot up to between 2.5 to 3, and then post-COVID, it dropped again to between 2 and then 2.5. If we want to look at it in terms of IT and computer science, we have relatively the same increase and then drop. But for computer science education, for the computer science students, the gap pre-COVID in terms of the CGPA was greater, the gap between the IT and the computer science, and gradually that gap closed up, and then post-COVID, they were actually at par. Then gender-based analysis. Generally, female performance increased, and during the COVID, and after that, the performance of females still maintained. There has been some research works that indicated that females particularly were very good at using IT tools in learning. So we attributed this increase to that. So in addressing research questions about how lecturers modified their teaching pedagogies during the pandemic or during the emergency remote teaching, we realized that they simply uploaded slides or ebooks during the first phase of the pandemic because of the emergency nature of the situation. You know, we just uploaded materials onto a learning management system for students to access. But as we move towards the second phase and then the post-COVID phases, there were more deliberate modes where our university in particular introduced a blended learning model where we had like 2 hours face-to-face and then 1 hour online. And then we also involved staff or instructors in capacity building workshops for them to understand the use of learning management systems. And then in terms of academic performance, looking at the discrepancies between learners' performance during traditional face-to-face and the emergency, we realized that there was approximately 24% rise in the average GPA during the first phase of the COVID-19 as compared to the average GPA before the COVID. But there was no significant difference in GPA before and then after the second wave of the COVID. So this inconsistency on performance suggests that educationalists cannot use the same pedagogical approach for teaching and assessing in face-to-face and then online environments. With the third research question, what are the variations in student academic achievement due to the instructional decisions made by emergency remote teaching? There hasn't been much change in the performance of students, that is before and then after. But there was a significant change in the performance of the female students. It has actually improved during the wave, and then after that, the female performance did not go below the initial performance, that is before the COVID, before COVID. So we are saying that higher education management should plan for post-COVID pandemic teaching and learning. It's supposed to be a deliberate thing. We are not supposed to wait for any unforeseen circumstance to come and take us by surprise. The COVID-19 has come and taught us some lessons, and then educationalists or management of higher education should take it seriously, such that a well-structured blended learning environment would be able to suit students, faculty, and then management in the future. The impact to society has been that students, COVID-19 has been very daunting on students. However, it has also paved a way to allow educationalists to explore alternative pedagogies to enhance learning, some of these pedagogies were there before the pandemic, but we never saw the essence in adapting them. But with the COVID-19, it has clearly showed that the time has come where we should be exploring alternative and modern ways of teaching. So we also looked at the probable use of multiple IT tools. Probably the single IT use, like just going strictly by a learning management system, was not helpful enough. We should be able to be diverse in the tools we use that could cover a range of students in terms of comfort and accessibility and affordability. So in conclusion, the research results indicate that it is essential for university management and authorities to plan post-COVID-19 pandemic teaching and learning adaptation. It is necessary to use appropriate research techniques to ensure sustainability of delivery of quality education, and the post-COVID-19 tendencies have been presented to permit new teaching and learning of computer science education, in particularly in Ghana. Yeah, so basically, we are saying that the COVID-19 pandemic has paved the way, and based on the analysis of the data we obtained on computer science and IT students, switching from face-to-face to online should be a more deliberate method and not spontaneous. There should be structures put in place to implement new pedagogies. These are some references. Yeah, thank you.
Thank you very much. Let's thank the speaker. We have time for a few questions. I'll just comment that I think while it was a transition that was difficult for students, I think pedagogically it pushed so many instructors to rethink what it means to teach, and I think it's been, as you have measured here, that it has had a net positive impact, although I wish we didn't have to go through this to have that. So, any other comments or questions? All right, thank you very much. So we're going to continue with the next talk. We will get back to Marie-Louise's talk a little bit later here. So now we're going to move to Dr. Roger Glass, and we're very pleased to have him here today. Just a moment. So Dr. Glass graduated from Harvard College in 1967 and received a Fulbright Fellowship to study at the University of Buenos Aires in 1967. He received his MD from Harvard Medical School and his MPH from the Harvard School of Public Health in 1972. Dr. Glass's research interests are in the prevention of gastroenteritis from rotavirus and neuroviruses through the application of novel scientific research. He has maintained field studies in India, Bangladesh, Brazil, Mexico, Israel, Russia, Vietnam, China, and elsewhere. He has received numerous awards, including the prestigious Charles C. Shepard Lifetime Scientific Achievement Award, the Dr. Charles Murrows Award for the National Foundation for Infectious Diseases, the Albert B. Sabine Gold Medal Award, Georgetown University's Cura Personalis Award, Research America's Jeffrey Bean Builders of Science Award, Rice University's Rice 360 Institute for Global Health Award, and the Jimmy and Rosalind Carter Humanitarian Award. Is this better? He is a member of the Institute of Medicine of the U.S. National Academy of Medicine, and he has co-authored more than 600 research papers and chapters. We are very honored to have you here today and hear your global perspective on building resilience to public health, crises and COVID-19 pandemic. Let's please give them a round of applause and welcome.
Thank you very much. Can you hear me? And let me put on my slides and see if you can see my slides.
We hear you very well, thank you.
And the slides are there?
Not yet.
Okay. Am I sharing my screen? Let me see if I'm sharing my screen properly.
We're seeing you right now.
I want to share the screen.
It's a little green thing at the bottom of the screen usually, or maybe there's
There
another.
you go. Is that shared?
It is, but it's showing the slides small and you big. Can we change that here? That might be on our end. Yes, now it's good. You're good to go. Thank you.
Great.
So
Well,
please.
listen, thank you so much, and I'm delighted to be with you this afternoon for you, and to speak about COVID and resilience to respond to public health crises and the impact of COVID, the COVID pandemic, and how that's changed our way of thinking. I'm the director of the Fogarty International Center and the associate director of NIH for Global Health. So this is the perspective I'm going to bring to you today. I was just in Kigali in December at a meeting of the Partnership for African Vaccine Manufacturing, organized by the African Union, the African CDC, NEPAD, and I was introduced, the program was introduced by President Kagame, as you see there on the slide. I had a chance to meet with John Nkangasong, the director of the Africa CDC, who was a Fogarty Fellow and an NIH grantee, and Michelle Sidibe, who's working on the African Medicines Agency. So it was really a wonderful time to see Kigali again. During my visit, I also went to see the opening of the first white coat ceremony for medical students at the new University for Global Health Equity. The chancellors, Paul Farmer, Deputy Chancellor Agnes Benaguajo, and Dean Zabebe Bekele. And I was really disappointed in hearing and sorrowed by the passing of Dr. Paul Farmer last month. And I really want to dedicate this talk to his memory because he was so instrumental in Rwanda in building research and building that university. I'm from NIH, which is the largest funder of biomedical research in the world. Our research is to pursue fundamental knowledge and to apply that to extend life and healthy existence and reduce illness. We're an agency that has a budget of $45 billion in this year, 2022, 27 institutes and centers, many of which you've heard of, like the National Institute of Allergy and Infectious Diseases, that's headed by Dr. Tony Fauci, National Cancer Institute, the Library of Medicine, which all of you in medicine probably access through PubMed. We're the two sides of NIH, the intramural program, which supports about 6,000 scientists on campus, but the larger part is that 81% of that $45 billion goes out to about 400,000 scientists around the United States and to 2,500 institutions. It also goes globally. And in fact, our funds can go to any outstanding investigator who has a unique idea or a unique population to study. So we have many grants in Africa. And all of our grants are judged through a rigorous peer review process. I've been very fortunate over the past 12 years to have as the director Dr. Francis Collins, who really was involved with the Human Genome Project. When Dr. Collins became director of NIH, he put a prime emphasis of his tenure to be expanding research in diseases of the developing world. And over the past 12 years, he's really done a lot, and we've done a lot through NIH to increase our funding of grants in Africa. Here you see some of the grants from a website that we host, worldreport.nih.gov. And you can use that to access any kind of research from NIH or a dozen other global funders. But you can see in Rwanda, we have about 17 institutions that are supported with really dozens of records, and it's been increasing over the last few years. So do go to that website, worldreport.nih.gov. When I thought about the pandemic, the last great pandemic was that pandemic of flu in 1918. And what's interesting is that that was truly historic, and this pandemic is truly historic, one that our children and grandchildren will remember. But what's also interesting is that at the beginning of this pandemic, we started without diagnostics, vaccines, or drugs, just like they did 100 years ago. Exactly the same. And all we had to work with was masking, social distancing, avoiding crowds, and those common public health containment measures, quarantine and the like. So where do we go from there? Well, this pandemic was first noted in China in November, in Wuhan, and the first publication about it was the publication of the sequence in January, about 7 weeks later. And that sequence was absolutely critical for us being able to think about vaccines and diagnostics that were essential to make a difference in this pandemic. But WHO only declared the pandemic in March, another 6 weeks later. And so what you see here is very important. It's about a 4 to 5 month range of dates from the time the outbreak was first identified until WHO declared this a pandemic. This underscores the need to have a global surveillance network where all countries can identify an outbreak, say within a week, so we can begin to get engaged in public health control measures, in control of travel, and other preventive measures to really stop its spread. These 3 or 4 months of that pandemic surging around the world made it a real, truly global pandemic. Well, with that, we've all been cognizant of the variation of strains as this coronavirus has evolved. We're now into the Omicron strain, but you can see the other colored strains. What's striking is at the beginning of this pandemic, only 3 sites in Africa could sequence strains of COVID. Only 3 when it's clearly so important to develop an understanding of the agent and its prevention. The first discovery of the first sequence in Africa was conducted by Christian Happy in Nigeria at the African Center for Genomics. Christian Happy really helped to put Africa on the map and change the narrative so that Africans are no longer just consumers of genomics, but are providers of new knowledge. And he was a Fogarty grantee and an NIH grantee in a program that we began 10 years ago called Human Heredity and Health in Africa. At that time, we never thought that those people we've trained over the past 10 years would be so instrumental in monitoring the strains of COVID as they evolve. Something totally new which had become part of routine public health surveillance of new pathogens and continuing evolution of old pathogens. So this is really something novel in this pandemic that we've never used before, and we really feel that every country in the world should be able to sequence their strains. But how can we do this? Sequencing is so complicated, it's so expensive. How can other countries do this, countries in Africa? Let me just move on to say that another grantee, Sikuleli Moyo, was another Fogarty trainee, now in Botswana as their lab director, originally from Zimbabwe, and he identified the Omicron strain first, and again, showing that people who have trained in the skills of immunology and epidemiology and genomics can really advance into an area where they've never seen the virus before, but they have all the tools at their beck and call. That Omicron, as you can see, and because of the sequencing that's available, you can see how rapidly we know that that has spread. And this is data within a month of the discovery of the virus, you can see its global transmission. How is this possible, though, to sequence so well and so rapidly? It's all because of novelties in diagnostics. And here you see 2 small sequencers, a nanopore sequencer that hooks up to your laptop and is relatively easy to use in any small laboratory in the world, and the Illumina sequencer, which is similar. So we have the capability now to do sequencing in any lab and follow this pandemic and the next and identify new strains. It's technology being added to our response to the next epidemic or pandemic. Very important. Well, at Fogarty, we've joined with the Gates Foundation, with the Africa CDC, with Institute Pasteur and others to set up training programs, virtual training for genomic epidemiology. And that's ongoing today. This is an early slide, but we're able to train people in genomic surveillance very rapidly through these virtual courses and supplying them with reagents. Something totally new. Now, the pandemic, you've heard already, over 6 million deaths in the world, probably double that number if we looked at those that were not, did not have a diagnosis specifically of COVID death. But it's affected us all. One of the issues, and I think Isaac presented this morning, Isaac Coffin, was that we don't have a central repository, a central group that is involved with monitoring and maintaining and ensuring the quality of data. This data is from Johns Hopkins, but in the US, we're getting data from the New York Times, our major newspaper, the Institute of Health Metrics. We really need a global system where data from throughout the world is validated for quality, where people use similar methods, and we have a single data source, something that I think Isaac was referring to in his thinking about how to get this data for Africa. When we look at the coronavirus by weeks, here we have the past week, and you can see that even in the United States, where we have 70% of our population immunized, we're still having a heating up of the pandemic of this latest Omicron strain, the BA.2 variant. We're learning all the time. The pandemic is not going away. One of the consequences in the US, as throughout the world, has been the shortage of equipment and supplies. Initially for us, the shortage of protective masks, ventilators, ICU beds, and the chaos that each wave has brought. So it's really been a challenge to our healthcare delivery system. It's affected all of us. All of you in the room today have been affected by issues of shutdowns of travel, supply of goods, business lockdowns of restaurants and schools, mental health distress that we just heard about from Pakistan, and the social and political chaos. So we're still learning about the virus today, 2 years after the virus has emerged. We're learning about its impact on every body system, the heart, hemoglobin coagulopathies, mental illness, neurologic sequelae, and the like, long COVID, as well as the efficacy of vaccines and drugs. Beyond that, some of the more famous economists in the United States have called this pandemic, the coronavirus, the $16 trillion virus because of its impact on our lost GDP, premature deaths, losses of all sorts, to the point where they've said that this has been the greatest threat to prosperity that the U.S. has encountered since the Great Depression. Economics is what all politicians are interested in. Well, what do we say then about the pandemic? Well, it's really a wake-up call, a teaching moment for the world. All countries are impacted. All presidents and politicians are engaged. All economies have suffered and are involved, and the people's welfare has really been impacted. And another feature that's been unique here is that African countries have been totally dependent upon international help for diagnostics, drugs, and vaccines, and PPE, and oxygen, and more. It's time for a major change. Well, we tried about 4 years ago with the Gates Foundation, the Wellcome Trust, the African Union, and the African Academy of Science to put together an initiative to promote research and innovation in Africa by engaging governments, private enterprise, international banks, philanthropy, to see what we could do to increase the spend on science and technology, which we thought was so essential. We brought together a group of African leaders to ask them what they needed to do to be able to get their governments to increase their investments in science and research, just as all of us donors, the NIH, the Gates Foundation, and the Wellcome Trust, have tried to do as much as we could do. And the answer that came back from these African leaders was very interesting. They said that we don't need more research per se, we need investments in innovation and in biotechnology, data science, entrepreneurship, and building a biotech ecosystem. And in the US, that biotech ecosystem is a real driver of our economy. So Africa needs to do the same and to make those diagnostics, drugs, and vaccines on the continent so they can be part of the solution. So there's a clear need to build science in Africa. There's certainly programs of the African Union to do so in the Africa CDC, but we have to move those plans from ideas to reality and to get sufficient funding to make this happen. Well, in the United States, we began to address this pandemic with a program called Operation Warp Speed. This effort was to deliver to the U.S. public 300 million doses of safe vaccine in less than a year, an incredible challenge. You know, vaccines normally take 6 to 10 years to develop, here 73 months. We were trying to develop vaccines in 14 months from the first identification of the virus. And so the government put in $10 billion with some novel ideas. One idea was to use advanced market commitments to pay about 7 companies to produce 1 million doses of vaccine each to be paid when they made the vaccine. Very novel approach to getting companies engaged. And also to use emergency use authorization so we could get more rapid approval by FDA of these vaccines. And the vaccine proposals that were funded by Warp Speed included 2 that were totally novel. The mRNA vaccines that were being made by Pfizer, BioNTech, and Moderna, a DNA vaccines, Janssen and AstraZeneca, using the vectors, replication defective vectors, recombinant subunits, and attenuated live vector platforms. These 2 first approaches, DNA and mRNA, had never been used before for vaccines, so this was a highly risky investment for the government. And yet, it turned out that these 2 vaccines, and particularly the mRNA, was the first one to succeed. The vaccine proved itself in phase 3 trials within a year of discovery of the virus and emergency use authorization for use in the US in December, in less than a year. It was really a novel discovery. And those vaccines are now in global use. There are half a dozen that are in global use. How do we get these vaccines to the developing world? Well, governments, Gavi, WHO, all got together to form the COVAX facility with the idea that countries in Africa would, within a year, get 20% of their population vaccinated. Those healthcare professionals and people at high risk and the elderly. But this has taken longer than we expected. We really need more help. And here you see the problem. By the end of the first of 2021, and really here in March 2022, 10 billion shots have been given throughout the world. The greatest volume of vaccines ever distributed on a global basis, but only about 8% of those have gone to Africa, which is a troubling issue of global inequity. And here you see African continent. So that's been one of the drivers to have Africa make its own vaccines and be part of the solution. Here you see John Nkangasong, the director of the Africa CDC, also a Fogarty trainee in epidemiology, who also worked at CDC in the US. He looked at this, he's been director for 5 years. He said, really, there are lessons for the world that we have to learn. And one is that Africa urgently needs to guarantee its own security. And with that, and working with the African Union, they put together this partnership for vaccine manufacturing in Africa, PAVM. And that's an organization to which I'm a member representing NIH. What are they doing with PAVM? They're trying to get African companies set up to manufacture vaccines as their key priority. They've already started this activity. There's several companies that are engaged in Africa with the hope of making vaccines by the end of 2022 or 2023. So this is actually a change that is starting now, but to develop vaccines will take 20 years to get a full complement. Key to that will be training a workforce skilled in the research and manufacturing of these complicated biologics. So PAVM has set together an activity chart of what they need to do, and it's in the area of research and development and the development of talent, and in vaccine research centers where NIH can really be most instrumental. This is the sweet spot for what we do globally. Well, here we are now, 2 years after, a year and a half after the epidemic started. In the United States, we're seeing a peak of this new Omicron strain. It was only identified in Botswana by Sikelele Moyo in November. Why should we be seeing this epidemic rise again? Well, what we know about it now is that this pandemic strain is more contagious than the early strain, but is less severe in its consequences. So we're still learning about this virus and how to monitor its consequences. But the bottom line is that we're not going to be safe with COVID and coronaviruses until we're all safe. And we're going to continue to see new strains emerging until we can control it more effectively. Other things we're learning, not from the United States, but here from the Israelis, who identified first that the duration of immunity was less in developing countries than in, was less after 6 months or so when we needed a third dose. First called a booster, now it's a 3-dose vaccine with an additional booster. And in the US, we're just going to 4 doses to learn about this. This is clearly important. We're also learning to deal with disinformation, something we never anticipated. And in the US, the pandemic continues to be a problem of the unvaccinated. Here you see the difference in rates of COVID in the high lines among the unvaccinated versus the low lines, the vaccinated. And you can see that there are tenfold more deaths among the unvaccinated than among the vaccinated. So we still have an educational lesson to get people to accept vaccines. It seems like something that shouldn't be so difficult when their health is at stake. But we found, for instance, that because of the politics and vaccine hesitancy, and the ways the vaccines were introduced, there's this big divide in the US between counties that voted Republican versus Democratic that led to a difference in their acceptance of vaccines. So the difference correlates into about 135,000 excess deaths, deaths that could have been prevented if people had been more accepting of the vaccine, something we never anticipated. Going beyond vaccines, diagnostics have been key, and at the beginning of the pandemic, we had no simple diagnostics that could be point of care in use. So Bruce Stromberg and the National Institute of Bioimaging and Bioengineering received a grant from the government, over $500 million, to rapidly accelerate the development, validation, and commercialization of new tests. Here you see the funnel process by which 3,000 applications were entered, rapidly screened, and through the screening process, 35 new diagnostics came onto the market. Here are just some of those diagnostics, but now we have free diagnostics in the US. We're behind some of our European partners, but they're now available and highly effective and inexpensive. So this has been a big addition to our ability to control the pandemic. We've also been involved in treatment studies of new drugs and vaccines, and many of these studies have been conducted at African sites. We have some approved drugs. We have many that were pseudoscience. Remember that hydroxychloroquine that was touted by the French early in the pandemic that did not pan out, or ivermectin. So there's a whole scale of vaccines, monoclonal antibodies, that are now being used for the most severe disease and recommended. So we have treatments now that we didn't have before, rapidly developed. We also have new knowledge that children in Africa are dying at rates much higher than children in the high-income countries. A study by Jean Nchenga, a grantee of NIH and Fogarty, who collaborated with 6 countries in Africa to demonstrate these higher rates of mortality, seeking a solution and recognizing that children need to be vaccinated, particularly in sub-Saharan Africa. Now, I go back to the data issues that Isaac presented because we've just launched from Fogarty and NIH with 15 of our institutes a data science initiative because we think that data science is, again, critical to building up our understanding of this pandemic and the next. Data science grants to 19 investigative groups, including Rwanda, in 12 countries, will help with mobile technologies for community workers, point-of-care diagnostics, viral surveillance and tracking, and precision public health. So we really see this as a way that we at NIH can help with dealing with the next pandemic and with the data issues involved. Also, engineering, bioengineering, biohubs will be needed to incorporate these innovations. We have grants in bioengineering. Here's one based in Cape Town in the US and Northwestern, but there are a number of these looking at how do we incorporate bioengineering, innovative projects that can get ministries of finance interested in responding to COVID. Another impact that we've seen is that we've seen the elevation of science in the US government. Dr. Tony Fauci has become the president's chief medical advisor, and Dr. Collins has become a co-chair of the President's Council on Advisors on Science and Technology. So we're getting high-level advice to the President's ear to make these decisions. So this is a priority that should happen throughout Africa and the rest of the world. The G7 has gotten involved and set up guidelines that they would like to see surveillance of new outbreaks within a week of detection, development of new vaccines in 100 days, something that would have been unthought of before this pandemic, as ways to invigorate our economies and secure our prosperity. So this is what we are hoping from the global G7 and their support. Well, what has COVID taught us about pandemic preparedness? How can we prepare? What can we learn? Well, my Deputy Director, Peter Kilmarks, and I looked at this issue from our perspective at Fogarty, and we feel that part of the solution to this will be to prepare the health research capacity, investigators who are capable of dealing with the new pandemic as it comes, as immunologists, as epidemiologists, as clinical scientists. So this is building the workforce for tomorrow. That workforce we've been working on for the past 30 years at Fogarty. So John and Kangason, Linda Gray, Slim Abdul Karim, they're all leaders in Africa dealing with these issues. They've all been trained through NIH and Fogarty programs, and they're really out there today. We need many more leaders to lead this effort. And we have programs at Fogarty that deal with medical education, education in the health sciences at all levels. And I would encourage you to go to our website where you can find and learn more about these opportunities. But they're at all levels for postdocs and fellows, for international research awardees who can get K awards just like American investigators, and emerging global leader awards. Again, great awards for young people with future careers in science. We also have programs in mobile health that in Africa, cell phones have permeated the continent faster, and there are more cell phones than toilets, I understand. But here you see a number of grants all around Africa involving global mobile health. And even in the United States, this pandemic has made telemedicine much more of a reality than it's been in the past. Telemedicine in areas where you have few physicians will allow community health workers to relate and interact and deliver care on a mobile device and to be the interlocutor between patients and doctors. And postdoctoral training programs, and here you see Francis Collins with our cohort of trainees. Well, we have to listen to African leadership about how to train for the next pandemic. And this article in Nature by Christian Happy and John Kengasan said, let's invest in health and disease, build regional control and capabilities for epidemiologic surveillance, accelerate translational research, invest in early warning systems, and build a centralized governance structure. These are words of your leaders that we fully embrace. And these are precious times. Today, we have the world's attention around this pandemic. Everyone's engaged, every president, every population sees what we need to do. And clearly, we need to benefit from this disaster, this pandemic, as an opportunity to do more and to get more invested in biosecurity. The African Union is working on this, the African CDC, African development banks. Lots can be done, and many presidents have shown their interest. Challenges going forward? Let's see if we can identify those outbreaks within a week through a global system that's now being discussed. Let's see if we can prepare new vaccines in 100 days. Let's see if we can do these, manufacture these innovations, drugs, vaccines, and diagnostics on the African continent. We really have to do a lot more. We have to grant biosecurity the same priority as we provide for military security. Lessons, Dr. Collins has put out lessons as well, supporting the PAVM initiative for vaccines, therapeutics, but he also says don't stop the investments when this pandemic ends. And we really have to continue to build that research, innovation, and leadership. Well, I want to end by encouraging you to visit the Fogarty website where we have funding news from all of NIH, much of which could be helpful to you as you think about building partnerships, which will be the secret to the success of building a long-term capacity in Africa. The themes of this conference have been what's the role of science and technology? And I hope I've explained to you, argued that this is absolutely essential to respond today and tomorrow. We have to invest in human capital and innovation and data science. We have to recognize that the next pandemic may be just with us tomorrow. And if we're not prepared, we'll suffer the same fate as we did this time with delays in mounting a response. Public health systems and innovative practices have to be built to respond more rapidly. And vaccines, we already discussed. Bottom line, we won't be safe in this pandemic and the next until we're all safe and we're all involved. When I came to Rwanda in December, my wife was very concerned that I was going to a place where I was going to capture COVID. But when I got to Rwanda and Kigali, I found that 90% of the citizens had been vaccinated with 2 doses. There was widespread screening at the airport and of visitors in and out of Kigali and on the streets, and masking was everywhere. And the Rwandans have done an amazing job, both with what you've done to date and with things like your plans for an mRNA facility to build the African Medicines Agency in Kigali next to a biotech park. In the engagement of Carnegie Mellon, as you see here today, in the African Institute of Mathematical Sciences. So there's a lot that you're doing already, but there's a lot more that could be done. In closing, I want to thank the host of this, Eugene Mudumara, an old friend and grantee, Marie Chantel, the organizer, Agnes Binagwaho from the University of Global Health Equity, a wonderful friend, and your ministers of education and health, both of whom have been conveners of this session. And finally, to end with a note from Nelson Mandela, a winner is a dreamer who never gives up. I think we have a huge challenge ahead of us to respond both to this pandemic and to the next one that follows. And the answer will be in science, technology, and investment in these, as well as building the research and leadership workforce for the health sciences. Thanks so much for your attention.
Thank you so much. Thank you so much. That was a great talk. I think it gave us a lot of insights and perspective, and we appreciate that. We have time for questions. If anybody has a question or a comment that they'd like to share, please go ahead. Yes, please.
I would like to thank Dr. Roger Grass for his talk, very insightful, very engaging. When I met Dr. Roger Glass last year in December at Serena Hotel, it was like a dream that we will be able to have you talk today at this conference, not because you are not committed, but because you really have a lot of engagement. But because of your love for science, knowledge transfer in Africa and elsewhere, you are able to give us this insightful talk. So I would like to thank you. Having said that, I would like to ask a question. Certainly, as you indicated, getting a grant from NIH will need a peer review process. That will always take a while. Besides what the government of US did, for instance, to support and fund research towards vaccine manufacture and expediting the process to ensure that emergency authorization takes place, how did the NIH go about shortening the process of funding research in the US and across the world? Thank you.
Wonderful question. First of all, we did get new appropriations for funding at all levels from the government. And you saw that in the diagnostic development, we used a down selection. We had 3,000 applications for novel ways to develop diagnostics. And they went through a rapid peer review on a weekly basis to down select. Also, we've just issued this data science grant, and you have one of these data science grants in Rwanda. You can adapt that. Now, that's a broad grant for training in data science, and you can adapt that to your own priorities. Those grants have gone directly to African institutions. You are the owners of those grants, and you can both use those grants as they are. You can apply for supplemental funds to include new priorities, and I think funding is in those grants, so it's there. And finally, so there are other supplemental funds if you have existing grants. So if you're working in an immunology lab, you can extend what you do to COVID, just like Christian Happy did. His grant was in human heredity and sequencing, but he moved right to work on infectious diseases. So there's a lot of wiggle room in some of these grants, and you have to talk to your project officer. For the emergency use authorizations, the difference between this and a regular regulatory approval is that for full approval for a vaccine, you have to cover a year or two of long-term adverse consequences. Yet most of those consequences occur in the first 2 months. And so this was a special idea that came up a decade ago or so to allow for just this situation. And we're still monitoring long-term consequences of the vaccine and also the long-term consequences on the ability of vaccine to protect against long COVID. So a lot can be done. We still go by peer review in general for novel innovations and knowledge, but for these situations, there are other things that we can do, build on existing grants. Great question.
Thank you for that response. And I do want to take this opportunity to give to say something about the host, NCST. I've been in Rwanda for almost 10 years, and I've seen how over the past few years they've really ramped up as a funding agency. They're looking more and more like NSF or NIH in the way they're behaving, and they're maturing their ability to fund research that's relevant locally here, and that's something that I think that we hope to see continue to grow, and I think that's something that can lead us to being able to do similar things as you were describing for the US. So again, I really want to thank NCST for taking that initiative and really pushing on that front, because I think that's really what's going to make science, strong science, deep science, a reality here in Rwanda. So thank you. Yeah.
I would also add the building of a biotech park in Kigali, where you have not only the research, but the innovation and product development. Carnegie Mellon being there and the African Institute of Mathematical Sciences, it really provides an ecosystem where the private sector can engage, can support innovation, can review what's happening, can make good business sense out of novel ideas. So there has to be an ecosystem built up, and I think you're really starting and are very nimble to do this in Rwanda.
Thank you for that. Other questions, comments for Dr. Glass? I have a question. Are we going to see DIS 2 in Africa? The investment that you made in last year was, I think, really important, and I think it energized and put a point on your comment that that the NIH funds things all over the world. Is there anything in the works for another investment like that for Africa?
I think that's a 5-year, those are 5-year grants. So we're really going to see how they work, and built into the grant is the opportunity to find new topics to include in your portfolio. So I think those people who have the grants were highly competitive on the first round, and they'll be able to extend out. They can also bring in people, other people and partners as they grow. So I think those will be our anchors for the next 5 years for DSI. But there are other grants that are available, and training grants and all sorts of grants, like the mobile technologies, which could be clearly adapted to dealing with data science issues. So look at the website, because about every 2 months we put out Global Health Matters, our newsletter, but every week or so we put out new funding announcements. So there's a place to look for what all of NIH is doing in the global sphere.
Great. If there's no further comments or questions, let's please thank Dr. Glass. Oh, sorry, there's one question here. Yes.
Thank you very much for a very inspiring talk. I was curious about the New York Times and the New York Times role and that they played in disseminating information to the public. I'd like you to comment on that and the role of other media outlets.
Yeah, you know, I spent 30 years at CDC, and CDC used to be the prime outlet for epidemic information through the MMWR. In this outbreak, for whatever reasons, the New York Times has hired some great people to do global surveillance. I read the New York Times every morning, and that's what I see. It's quite amazing. The Institute of Health Metrics in the University of Washington has their own networks for data collection. And Johns Hopkins has done a superb job, and I showed some data. This should really be a quality activity that's done on a global basis, global governance. And right now we have, as I think Isaac mentioned, about 10 different groups doing global surveillance on data, culling the same data. What we really need is better data and more reliable, interpretable statistics and better analytics. I think that's something that will hopefully come out of this pandemic and help us in the future. So.
Very good, thank you. We're going to have the final talk of this session. That'll be Marie-Louise Nsayi-Senga. She will speak about reflections on the learner's resilience towards education continuity during the COVID-19 pandemic in Rwanda. And I understand that'll be a live presentation, which will be great. Marie-Louise.
Good afternoon, everyone. Thank you very much for this opportunity to share with you the findings of my research entitled Reflections on Learners' Resilience Towards Education Continuity During COVID-19 Pandemic in Rwanda. You know, I'm Marie-Louise Nsayi-Senga from University of Rwanda. I'm presenting on behalf of my team. We are 6, 3 from University of Rwanda, other 3 from an NGO entitled Envisage Rwanda. We are conducting, next. This presentation consists of brief background of the topic, relevance and novelty, objectives of the study. Then I will talk of the results and discussion, impact to the society, then the conclusion. Next. As I told you, this presentation is part of a bigger project entitled Analyzing the Resilience of Primary and Secondary Education to Mitigate the Impact of COVID-19 Pandemic in Rwanda. So this paper is the outcome of this project. As I told you in the background of this study, as you may know, before the pandemic, the education system of Rwanda was performing very well with admirable results in enrollment rate and completion rate both in primary and secondary school. But in March 2020, with the outbreak of the pandemic, the government of Rwanda decided to adopt serious measures to curb the spread of the pandemic. Some of the measures include the school closures. So with this school closure, learners have to go back home. They have to stay home because the continuity of education was not possible due to social distancing. So after that, the government, to mitigate the impact of the COVID-19, it decided to adopt the distance learning or distance teaching, where learners have to learn from their home. You know, this shift from face-to-face teaching to online teaching resulted in a number of challenges. It was not easy because the education system was not ready for that. As far as the relevance of this study is concerned, this study is among the interdisciplinary research which is conducted in educational area. It also consists of opportunity for operationalization of research-driven collaboration between private and public institutions. Also, the study is relevant because it created the space and opportunity for capacity building and mentorship. The study also provides useful data for educational stakeholders while planning programs to tackle the impacts of COVID-19 on primary and secondary education system in Rwanda. Last but not least, the findings of the research also inform educational actors on how to strengthen remote learning mechanisms for improved resilience of Rwandan primary and education during the COVID-19 pandemic and other similar times of crisis which may occur. The aim of this study was to investigate the preparedness and effectiveness of new remote learning mechanisms in teaching and learning process at primary and secondary education levels in Rwanda. Specifically, the study aimed at analyzing learners' experiences about online learning during COVID-19 lockdowns toward building a resilient primary and secondary education system in Rwanda. Number two, it also wanted to identify tools used in distance learning and assess their effectiveness. Next. So, as far as the results are concerned, it's worth mentioning that the results were collected nationwide. The results were collected from 10 districts from all provinces of Rwanda. The respondents consisted of 51% learners from secondary schools, while 49% were from primary. Those learners were from public schools, which consist of 73%. Private schools were 26%, while private international programs were only 2%. Next. Also, we looked at how the continuity of education was during the lockdown. Then we found out that 77% agreed that they continued to learn during the lockdown period, while 23% didn't continue to learn. Next. So, from the chart, you can see that we also try to compare male and female as far as the access to online education was concerned. Then from primary, we found that 30% didn't have access to online learning, while 53% accessed the online learning from primary school. While secondary learners agreed that 71% didn't access, then 45% accessed online learning. For female, 38% didn't access from primary school, while 52% accessed online learning. For secondary, female, 62% didn't access, while 48% accessed online. Next. Next. Okay, so the previous one. Sorry. We also tried to compare rural and urban areas. Then we realized that 61% male from rural areas didn't access the learning during the lockdown, while 56% male from rural accessed e-learning. For urban, 40% only didn't access the e-learning, while 43% accessed e-learning. For rural female, 62% female agreed to not have accessed e-learning, while 58% accessed e-learning. Next. So if we, after realizing that not 100% access to e-learning, we tried to see what other activities learners were involved in. Among those activities, some agreed that they were doing housework during online sessions. 50% told us that they were doing housework, others just relaxing, watching TV, playing games, doing casual work like aid construction or being involved in small businesses. Other learners work in farm, especially in rural areas. Then there were others selling things like eggs, envelope, face mask, which consists of 30%. Next. During online, also different tools were used. A big share agreed that like 40% they accessed online education through revising the courses given before the pandemic. So they were reading books and notes taken before the pandemic. About 18% used mobile phones, while 17% accessed e-learning through radio broadcasts and television show consists of 15%. Internet downloadable materials also consist of 8%. There were also the use of other virtual classes like Zoom platform or Google Meet. Also, it consists of 3 or 4%. Next. We also tried to assess the effectiveness of the online instruction basing on those indicators, facilitating the social distancing. This means whether the learner could find enough space for online learning. Then we found out that 31% agreed that they had enough space or enough time to follow online learning. We also wanted to know whether they had some kind of parental support. Then 20% agreed that they had it. Whether children don't abuse their lessons, 19% agreed that they didn't do that. Working flexibility, for example, if they were given homework, we wanted to know whether they find it wonderful because they can do it anytime. Then only 30% agreed that online instruction consists of or facilitate working flexibility. In terms of cost effectiveness, whether they find it the online instruction cost effective, 7% agreed that they find it cost effective. Also, we looked at time efficiency. We took an average of 15 minutes by course. Then only 4% agreed that they spent like 15 minutes on the course. If we asked them about the hope for the course continuation, you have to remember that this is the online instruction where schools were closed. Only 4% agreed that they had hope for course continuation. Next. Also, the overall online instruction effectiveness consists of 70% told us that the online instruction was not effective, while only 30% agreed that it was effective. Next. Also, we identified some challenges faced during the online learning. So the first challenge was lack of motivation because of different reasons. Also, there was a lack of ICT equipment, including computer, mobile phones. Some families didn't have access to this material, which also constrained a big hindrance to the success of online education. There was also the lack of time because of people being busy in the housework or limited English language proficiency. As you remember, the medium of instruction in Rwanda is English, and you know many people, especially from rural areas, they have limited proficiency in the language. Also, the online education was constrained by lack of support from parents and from teachers and limited ICT skills. Next. As far as the impact of this study to the society, the study provided coordinated initiatives from different education stakeholders. It also resulted in synergies and partnership between public and private sectors. As I told you, this project is conducted in partnership with the University of Rwanda and an NGO. Also, there is another impact is timely information and intervention. Timely information, which resulted in timely intervention. Then there is search also resulted in the research, communication, and networking to address societal issues in particular and educational. To conclude, there is a need to develop skills and access to tools to ensure the continuity of education during the pandemic and school closure. Also, there is a need to leverage on collaboration and partnership between government and development partners in the educational sector to strengthen remote learning system from primary and secondary schools. Also, we need to expand remote learning opportunities through radio and television broadcast and the other digital tools to reach out to all learners. Last but not least, build on lessons learned during the pandemic to improve our preparedness against any future crisis. So these are some of the references. Next. Now, I cannot end this presentation without thanking the government of Rwanda through the Ministry of Education. I also want to extend my thanks to the University of Rwanda and the NCST for funding our research, because without the funds, this research could not be possible. I also want to thank learners who participated in this study, teachers and head teachers. Thank you very much.
Thank you, Marie-Louise. Do we have questions from the audience? Comments? Yes, please.
Thank you very much for the very good presentation, and especially it's very interesting. I would like to reflect on the accessibility. So you said that there is accessibility of 61% for a certain category of people, and then another findings of effectiveness at 30%, and another finding of the use of 3% of people, the children who can use the digital devices. So how can you reflect on that and then provide a message on that? How is it can be effective? Thank you.
You know, thank you for the question. But I know the analysis of data is done basing on, for example, the location of schools or the gender. If I say, for example, 61%, if it is from rural area, it is based on the location. For example, all people who accessed the online learning in that area is considered as 100. Then that 61, it is not in relation to the whole number of the people. It is in relation to the people who accessed the e-learning education, but from rural areas. Do you understand me? If, for example, because the data are analyzed according to their gender and accessibility and non-accessibility, or rural and accessibility and non-accessibility.
But I think one of the questions is, you're stating it as, for the category of, say, gender, accessible, not accessible, you're saying 61%, for instance, said it was accessible, and 58% said it was not accessible. But that adds up more than 100.
If, for example, you can go back to the slides of analysis, I can explain it more. Can I have the slide of, not this one, where we have bar charts? If, for example, here, you can see we have primary, we have secondary, we have male. If you can see, for male, we have also two indicators, no access and access. Do you understand me? So the blue one stands for no access. If it is primary rural, if it is male, it means it is 100. You can see 30% from male are from primary school who didn't access e-learning. Do you understand me now? Yeah,
the two
blue, they stand for no access.
And they add up to 100, and the two red add up to 100. Okay, good.
And you see the red stands for access. Male access, they are red here in the first column. You can see 54% accessed e-learning, while 55 didn't access. That's how the calculations are done.
I see. Very good, thank you. Are there other questions?
Yes.
Comments? Yes.
Okay. Thank you so much for the great presentation. There is a slide where you say that 70% of the respondents said that the online instruction was not effective. I would like to know why. Like, did the research investigate why? And then are there recommendations for future improvement? Thank you.
Okay, thank you. We try to find why, and among the reasons given to us, there are lack of hope for continuation of schools, reopening of schools. But you remember that this online education was not taken into consideration, although learners spend almost 1 year learning online. When schools reopened, many schools, they have to repeat the year. So that one was one of the reasons. Another one was that sometimes a number of learners had limited access to ICT tools, which were mainly used in online learning. Others, in rural areas, a number of families, they don't have access to electricity, although they have to follow some sessions on radio, sometimes they get cut off electricity, or they don't have electricity for the whole day, so they missed some sessions. You have also another reason is that, you know, even if many learners were following courses, but there were no official examination, there was no assessment. So it was just teaching for the sake of it.
Okay, a follow-up question on that. Have you investigated on the role of the teacher throughout the process? Because I think a teacher has a big impact on the way instruction is delivered to the student in that distance learning.
Okay, yes, of course we did. As I told you, this is one part of the project. We investigated the role of a teacher, the role of a parent, and the role of other educational stakeholders in the success of the online learning. Thank you.
Thank you very much. Let's give another round of applause. So I have a proposal which we can discuss here. We have one more talk. It's a keynote talk. And the schedule is we have a half-hour break and then we watch the talk. I think it might, and then after that we go to the exhibition booth. I have a proposal that we just do the last talk now, and then we can have the break. We can socialize, use that time, and see the booths at the same time. Any objections or any alternative suggestions or? Okay. Okay, we have a contingent here agreeing, others agreeing. Okay. Anybody wants to take a break now? Half-hour break? All right, let's do it. Okay. So our final talk today is Strategic R&D Investment for Improved Innovation to Mitigate COVID-19 Pandemic in Developing Countries. This will be presented by Mr. Stefan Leslie, Chief Executive Officer of Research Nova Scotia. Stefan is the Chief Executive Officer of Research Nova Scotia, an independent and nonprofit corporation with the mandate to organize, support, and coordinate the funding of research in the province of Nova Scotia, Canada. RNS manages approximately 450 research grants at any one time, annually providing 15 to 20 million Canadian dollars for projects, people, and infrastructure. Since the beginning of the pandemic, RNS has supported 23 COVID-19 research projects, including those related to vaccine development, testing strategies, virus detection, social and cultural impacts of the pandemic, and technology to reduce disease transmission. Mr. Stefan has a bachelor's degree in international development and a master's of marine management, both from Dalhousie University, Canada. So this is going to be a remote presentation. Let's welcome the speaker.
Good afternoon, everyone. Thank you for having me. My name is Stefan Leslie. I'm the Chief Executive Officer of an organization called Research Nova Scotia, and unfortunately I can't join you in Rwanda today, so the meeting organizers have kindly arranged for me to provide these remarks virtually. And so I'm recording these half the world away and hope that you find these interesting. So what I was asked to speak on today is the title, Strategic R&D Investments for Improved Innovation to Mitigate COVID-19 in Developing Countries. And I'd like to thank the organizers for including me in the conference proceedings. What I'd like to do is reflect a little bit on what we've learned here in our research and development efforts to combat COVID-19 in the hopes that some of this is of value to the circumstances you find yourself in there. So the agenda today is I'll spend a few minutes introducing Research Nova Scotia so you understand the perspective from which I come. I have about 20 slides and we'll be speaking for about 30 minutes, and then we'll have some time for questions at the end. So after Research Nova Scotia's introduction, I'll talk a little bit about all of our COVID-19 research work, and then reflect on what some of the successful elements were and perhaps some of the not so successful elements as it relates to COVID-19, and highlight some of that work and speak about a way forward on where we might take this in the future. So Research Nova Scotia, we are an independent, not-for-profit organization, and we fund research across many disciplines. So we're not just a health or medical research organization. We are involved in natural and social sciences, engineering, and so on. But of course, over the past couple of years, like much of the world, we have devoted a significant amount of our attention to COVID-19 research. So our mandate is to support, organize, and coordinate the funding of research in Nova Scotia. And Nova Scotia is one of the provinces of Canada on the extreme east coast on the Atlantic Ocean. And we sit not as the only funder of research in the funding landscape in Canada. So in Canada, there are, at the national level, research councils that also provide significant amounts of funding for research. So we exist at the subnational level in the province of Nova Scotia, where we work specifically to identify where research can be aligned with the priorities of the society here, those provincial priorities. So there are other organizations that are also have a really important role in funding research. And so the comments that I'm making today are really from the perspective of an organization that has as its concern a smaller portion of the country, but also very much needs to ensure that that funding is aligned with the needs of society. So we manage approximately 450 projects on an annual basis, about 15 to 20 million Canadian dollars per year. And we operate on the four premises that you see at the bottom of the slide, that there are areas of economic, social, and environmental importance for which research has an important role to play. There's lots of issues where research is less important or has less of a role to play. It's more one of implementation, but there are significant issues where bringing the capacity of researchers can really drive economic, social, and environmental improvement. And we believe that if we invest those resources well, we can actually make a difference. So we very much have the view that our objective is to realize those economic improvements to society, health, and so on. Research is a long-term prospect, generally speaking, but as an organization, we also need to act quickly in the face of not just global pandemics, but when opportunities arise, we need to be able to move quickly to take advantage of those partnership opportunities, even if some of those activities exist or will continue over the long term. And a lot of the issues that we are dealing with are big and complicated and may last generations. And so that also requires creativity in our approach to them. So how we work, I've really kind of boiled it down to three key things. And the first thing I want to draw your attention to is the subheading, which I've titled the Public Research Agenda. And I really want to focus on this as a need to fulfill things that are important to society. And so that's the public component of it. The society needs to be front and center to what we do. And that really flows into that first area of how we work. We start with what it is we want to accomplish. What is the risk or the opportunity to society outside of the research community that we would like the research capacity to address? And that if we can articulate or conceive of what those risks or opportunities are, then we can then turn those into more specific challenges that we can then bring the research community to help to solve. So we can actually mobilize all that creativity and independence of the research community, but guide it or direct it towards those opportunities or risk to society. And so if we focus those efforts on key priority areas where there are those needs, then we can focus on achieving results. So that's the first area. The second is once we've got those pieces aligned, then we can actually bring the research community together and invite researchers to contribute to those goals and actually contribute to the results that we're looking to see. And then the third piece is that although we do fund some things on our own, we are almost always working with partners who may join with us in the research side, or we're looking to work with those who are going to apply the research to a particular social or health or economic issue. So that would be governments with industry and communities, because we're very much looking to move from knowledge into implementation. So I want to take a moment here to talk a little bit about research quality and impact. And first, this has to do with how are we defining what good research is, or what's worthwhile, or what should we be funding? And there's been a lot of work around research excellence and what that means. And from 2018 or 2019, Science and Public Policy had a really interesting paper on this that looked at research excellence. But what I'm interested in here is where within this definition of excellence does the effect on society from high quality research get considered? And so we want to move beyond the markers of what is considered strictly within the research community, possibly as high quality research. And so I want to move from model 1, where you see on the left, where the objective of the activity is to support high quality research, which is original, significant, rigorous, and so on. And the condition of support is that there is a public benefit. And really we want to move to the second model where you actually switch those two. And the objective is to identify the relevance of the research itself. So what is that public benefit? And the condition of the support is that we're looking for top quality research in order to meet that objective. Now, there are other organizations that have different models which are needed within the research ecosystem, but Research Nova Scotia really does work towards that second model. So now that I've given you a bit of an introduction to Research Nova Scotia, I want to turn to the activities that we've done in support of COVID-19. And I'll start with this overview, which begins with what it is we want to accomplish. And so within our health or medical research, or research that is focused in that area, on the right-hand panel, you'll see where those 4 outcomes or things we want to achieve are articulated. And so you'll see that we want to advance disease detection, strengthen the healthcare delivery system, care for vulnerable populations, and every research project, every research initiative that we support as it relates to COVID-19, we always have in mind that that's what we're looking to achieve or accomplish. And so with each project that may be addressing vulnerable populations, we're looking for that connection of how the research can be implemented to actually provide support to the more vulnerable components of our society. So what I'd like to do now is kind of give you some highlights of what we do, or what we've done, and in particular draw attention to our view that COVID-19 has not just been a medical or health challenge, but it is also the defining economic and social challenge of our time. It has tended to overshadow or certainly color our approach across a number of other areas of society, and has really drawn the link between a functioning economic society and a healthy population. So our activity equally has been involved in health issues, but also economic and social dimensions as well. So some of the highlights are, we have, since the beginning of the pandemic in March of 2020, we funded 22 research projects related to COVID-19. We have spent just over 4.3 million, but we have worked with other organizations. So those projects in total have had a project value of just over 12 million. And as I mentioned, we've been active in lots of different dimensions. So everything from vaccine development to social impact have been the recipients of some of our work. And I should also point out that we're not just a granting agency. It is not just the funds that we provide, but in many of these projects, we are actively engaged in working to shape that project, to find additional investigators, to connect the research to those organizations who will actually implement the outputs of that research. So on this slide, I've taken an example or several examples. So first of all, each of the rows show general categories of the sorts of research projects that we've been engaged in. So in clinical discovery, maybe that's the kind of the first or most obvious. We have funded David Kelvin, who's at this conference, to work on identification of biomarkers. On response, for example, there's 2 projects there, but one on how we may be able to use artificial intelligence in actually guiding how we're going to test and treat COVID-19. On the health policy side, 2 more examples, how society responds to a pandemic is partly a reflection of how a variety of different organizations, whether they're businesses or public sector, actually responds to the disease. And so that is itself a research agenda. And of course, we've looked at disease impact as well. And so to take one of those, impact on community-based dementia care, we have an aging population in Nova Scotia. The impact on those who are in the community but are suffering from dementia is a matter of research to understand what the impact is there as well. So where I want to spend most of my time, though, is reflecting on what I've actually learned over the past 2 years after all this money and all this time and all this effort. So what have we learned? And I think it's really 3 things. And I want to spend a little bit of time exploring these. The first is that the potential benefit of the research for society has to drive the research agenda. Now, this is one of the founding concepts of Research Nova Scotia, so it's an easy thing to learn as it relates to the pandemic. And there are other organizations, as I mentioned, who are contributing to research, who may be driven by other needs. But for us, it is not just about what is interesting, but it is the identification of what is worth doing. But it's really the second one that I think is, if I could leave one thing behind today, the second point that I've put on the page are the most important. And that is that the elements of discovery, feasibility, acceptability, and implementation are separate components of research, but they have to be integrated, either within a single project or as a part of a set of connected efforts. If we are going to see that benefit to society, discovery or even sharing of the information from that discovery is not enough, that these other elements need to take place. And so what I mean by discovery is learning whatever it is about a natural phenomenon. So that is the scientific process being applied to something so that we understand more about a natural phenomenon or a social issue. But this matter of feasibility, that tends to reflect on external factors that may be adjusted. And so feasibility would include, is it cost effective? Is it affordable? Can we do it with the technology that we have or can build and the people that we've got? Because if we are looking at projects or the outputs of discovery then lead to implementation matters that cannot be feasibly done, then we're not going to see that benefit to society. The acceptability piece is more of a social process. And so that addresses what may be considered ethical or socially accepted within the culture or mores of society. And then finally, implementation. So can we actually transition from research into practice? So the sorts of questions that one would find here is, would the outputs of this research be considered a priority for implementation, worthy of political attention, a broader implementation budget? Is there the institutional capacity to actually implement the findings. So if we're being driven by improving society, we need, as a set of projects or within a project, to really focus on all four of these different aspects. And then finally, what I've learned is we need to work with the willing, those who are passionate, interested, and buy into those first two pieces, and then to invest in them, and then to invest in them again. That's how we're going to get those results. So I now want to focus on two projects. And the first one is protecting residents in long-term care under the direction of the lead investigator, Ken Rockwood at Nova Scotia Health. And I've chosen two projects that demonstrate all of the things that I've just presented on the previous slide, but that also are large projects that kind of encapsulate all of those different features and aren't necessarily relying on factors outside or projects outside to bring matters of feasibility or implementation. So let's start with defining the problem. What was the issue here? So respiratory illness is a significant problem in long-term care facilities. As I mentioned, this is not just a COVID issue, but we have an aging population, an increasing proportion of whom are living in a communal setting in these long-term care facilities. And as people age and dementia becomes a greater feature of an aging population, these and other factors can reduce the efficacy of other public health measures that are used to manage respiratory illness transmission. So masks, social distancing, and hand washing may be more challenging in that kind of setting. So those are the problems that we set out to solve. So then taking those and then applying this discovery, feasibility, acceptability, implementation, we said, well, can you use a particular technology to reduce illness and infection? Can you actually install them in the facilities that we have? And can you afford it? Will people accept it? And does the regulatory structure governing the use of medical devices and these kinds of interventions actually allow it? Those who run a long-term care facility, can they actually implement it with the engineering team that they have? So all of these questions were built into the research project itself, which at the bottom of the page is described. It was a double-blind randomized control trial where we had an intervention and a placebo in two facilities that had very different resident profiles, multiple locations in each within each facility. And what it took was developing that methodology, dedicated research nurse, an ophthalmologist on staff to look at potential impact on eyes among the aging population. But very much a feature of this project was engagement, discussion, and information all along the way. And this, for a type of technology where the use of UV light to disinfect has been known for over 100 years, and in fact has been used to sterilize medical equipment, has even been used to sterilize the ambient air in rooms such as surgical theaters. But the discovery here is, can you implement that kind of intervention with people there that doesn't rely on the circulation of air to move the aerosol particles, that is the vector of disease transmission, into the path of the UV light? So can you integrate regular use of space with this kind of intervention? So that was the interesting part of it. The second project I want to spend a little bit more time on is tracking COVID-19 and wastewater. And this is under Dr. Graham Gagnon at Dalhousie University here in Nova Scotia. So what's the problem here? We know that we want to know where COVID cases are emerging and act, if at all possible, before they spread. In a situation where we cannot rely on individual testing at the frequency and scale required. We simply don't logistically or financially have the capacity to be constantly testing. So we need to find some way to do pooled testing or to set up a sentinel system to monitor this outside of expecting individuals to get tested for COVID-19. So again, applying those four different criteria or those four different consideration areas, is the question is, can we actually detect a viral signal in advance of clinical confirmation? not just at the community level, but also at a facility. So that may be a building, or it may be a neighborhood. And this has to function where there is a very low level or a high level of disease prevalence or viral prevalence. Can it be installed in the facilities we have? From an engineering perspective, can we actually deploy the equipment needed to do the sampling? Are there ethical concerns? Will the results be trusted? And again, this implementation is going to depend on whether those who are charged with making public health choices with highly diverse, but also degree of uncertainty in the information, are they going to actually use that to make choices about how to deploy testing or treatment resources? And perhaps most importantly is, even if it's being developed for COVID-19, can we apply the methodology to other issues or other areas where the engineering may be different, or how the pathogen of concern is actually transmitted within wastewater? So the research project included technology development and testing methodology. It includes both community monitoring at a wastewater treatment plant, as well as a separate monitoring system for an individual facility at a specific site, and an integration with epidemiological information to connect that information about viral load in the wastewater and disease severity that we've seen through clinical information. So the fundamental concept is you have a population of people in the middle of the top panel. If you go to the right, there are cases that are confirmed through clinical processes to get that epidemic curve. Those people may transmit to others. The virus is shedded. The SARS-CoV-2 virus that causes COVID-19 is shed through wastewater. And then at the bottom panel, we can either do sewer sampling at smaller locations, or we can do wastewater treatment plant sampling for a much larger population. And that gives you the viral signal in wastewater. So this is not in itself a unique approach. This is from yesterday or day before yesterday, a snapshot of a dashboard that's available online that shows all of the different wastewater treatment testing sites around the world. So over 3,000 sites, lots of different universities, lots of different countries. So this is a truly global effort. And so the innovation here is not really around, can you detect the presence of SARS-CoV-2 in wastewater, because we know we can, but we want to know, how do you actually make meaning out of that? How do you take those results and actually implement it into a public health decision-making system? And how do you apply the same kind of techniques, the same kind of technological development to a range of other problems? So this is what we found on the community monitoring side. So the top panel shows the clinical confirmation, and both of the two panels start at the beginning of April of 2021, last year, and end in September of 2021. So it shows about a 5-month period. And so you clearly see the clinical confirmation of an infection wave. And so this is for a portion of Nova Scotia, and it shows both the number of active cases and the number of new cases by day. Presented below on the same time scale is the results of the wastewater treatment plants. And we have in the city of Halifax, where I'm sitting, 4 separate treatment plants. And so they're listed here as A, B, C, and D, and are presented with different colors. And a number of things should jump out when you compare these two curves. The first is, of course, is that the top is relatively smooth and the bottom one is a bit noisy. The signal does jump around. The other, perhaps more important thing is, as you will see at the beginning of April, we began to see the signal in the wastewater before clinical confirmation of cases. In particular, wastewater treatment facility B, but then it grew to C, and then it grew to D, and then it grew to facility A. And so we had about 10 days to 2 weeks ahead of time the expectation that clinical cases were going to grow. Of course, on the other end, you see that wastewater treatment plant detected signal linger long after those clinical cases had resolved. And so wastewater monitoring or wastewater surveillance is not going to tell you exactly what to do and when, but it is going to give you advance notice, but it is also going to continue to be present after the infectious phase has ended. So for the facility or neighborhood component, it was a completely different technology. So what was developed and hanging from that string on the picture in front of you is a 9-centimeter diameter plastic ball that was 3D printed. It costs about $1 to produce. It splits in half, and on the inside is some filter paper. And what happens is that ball is lowered into the water stream. The COVID-19, SARS-CoV-2 particle in wastewater is actually absorbed to the filter paper inside. And so it is that filter paper that then goes into the lab where the detection is done. And so you'll see in that photo, this is sewer access. It is very simple technology where that plastic ball has holes in it to allow water to flow through is attached to a rope and dropped down into the sewer system and retrieved every 24 hours, that filter paper removed and the testing done. So the work with these individual community focused balls of sewer cage balls have been sent across the country and to a number of other places around the world as part of the global effort to increase our capacity to use wastewater surveillance as a means to monitor for SARS-CoV-2. But there is nothing currently in Africa. So I do want to spend a moment and actually think about that. So this is going back to the dashboard of locations of wastewater facilities monitoring for SARS-CoV-2. And you'll see, of course, there's clusters in America, in Western Europe, parts of Australia and New Zealand. And so if you line that up to GDP per capita or life expectancy or where existing disease burden is, you will see that what has happened is that the majority of effort as it relates to surveillance for wastewater, for SARS-CoV-2 in wastewater, is occurring where there's the highest GDP per capita, the highest life expectancy, and the lowest pre-existing burden of disease. So while we may be learning things, we have not necessarily put our efforts globally where the greatest risks to society actually exist. And then the final one, this is something that The Economist put out a few weeks or months ago, is when looking at where the potential areas for the emergence of variants of concern, we have also not deployed this kind of wastewater surveillance where those variants of concern are most likely to emerge. And we may not be using wastewater to actually test for variants, but it's where that surveillance is occurring where it's most easy to deploy that kind of testing for variants and is probably most important for that early detection. In other words, we want to know most urgently where we're seeing an increase in infection, where there's also a coinciding location for a potential for a variant. So what are we trying to do about it? So what we think is, and this is in the very early stages, we're working to develop a partnership in Rwanda to track the prevalence of not just SARS-CoV-2, but other pathogens of concern at sites across Rwanda. And so this is the very early stages. We're just discussing what might be possible, but we're talking about all those same things about a sampling method, developing methodology that will make the sampling as straightforward as possible with available technology, test at multiple sites, integrate with epidemiological information from the country itself, and then find a way to formulate that into decision making, not just around COVID-19, but other potential epidemics, or indeed other pathogens of concern that may be endemic, but for which there are times when there are rapid increases in infection. And so we have already had discussions with our colleagues in Rwanda at the Biomedical Center and the Water and Sanitation Corporation. And my colleagues at Dalhousie University, along with Research Nova Scotia, are having those discussions. But we're very much looking for developing something where there is a project for which others can join and for which is most relevant to the issues that you find in that particular location. And if we're able to kind of come up with a system that's going to work, we actually have the possibility of developing something through this project that will be world leading in its way of integrating this kind of novel surveillance system with the implementation component included, such that it flows from the research into decision support as seamlessly as possible. So with that, I'd like to end. This is our contact information. We have lots more information on our website. There's lots of information about our other research projects. That is my direct email address. Certainly invite you to continue, and you'll see at the bottom of your screen, we're highly active as an organization on a range of social media platforms as well, and I invite you to subscribe there or to check that information out, and I look forward to questions and answers and discussions from this point. Thank you very much, and I wish you all the best.
Thank you, Stefan. I believe you're also online now, that you could answer questions. Is that correct? Are you available, Stefan, to answer questions? Oh, yes. Working on the sound, one moment. I think you can hear us, so maybe we'll get the questions and then we'll work on the sound at the same time. Any questions for Stefan? Ah, yes.
Okay.
Coming.
Okay, thank you, Mr. Stephen, for a nice presentation. I have been interested by your project you have to do in Kigali, in Rwanda, to sample wastewater. Have I seen you are using the sewage system or wastewater treatment plants to take your samples? But here in Rwanda, most of wastewater is correct. I think for the sewage, it goes directly into the pit, latrines. We don't have a common wastewater treatment plants, municipal ones. I wonder how you will be how are you going to manage to take your samples? Are you going to use the pit latrines, or you will be just taking water, getting out the bathrooms when we have these modern ones? Or is it this virus surviving a lot of time so that it can be used to control its contamination in surface water? Thank you.
Are you able to hear me in the audience there?
Loud and clear.
Great. So thank you for that question. Really interesting thing to explore. So of course, we were developing this given the infrastructure that we had here, which does depend on the flow of water. That said, the application has been used in systems where there is not a common flow sewer. So where there has been a pit collection system, which is periodically emptied, and the device has actually been placed in the outflow during the emptying process. So that still has used the flow of water. One thing we need to look at is whether the capacity of the filter to which the SARS-CoV-2 actually adheres is able to function if there is an absence of flow through it, whether it gets saturated and therefore you'd lose the signal in the system that you're describing there, more the pit latrine system. So that would be one of the engineering technological issues to address to see how we might be able to apply what's been learned here into different circumstances. I think part of what makes this kind of work exciting is the desire to reflect an underlying approach, but to allow it to become customized to a range of different situations, reflecting the engineering or the sewage treatment approach that exists in the place in which it is deployed. So that becomes part of the discovery process to identify how that connection can be made.
Thank you. Another comment or question?
I want to thank Stephen Leslie for his insightful and very enriching talk. We are very honored and we thank you very much for your time and commitment. I understand you are working with teams at Rwanda Biomedical Center and teams in Rwanda to work on this project on testing pathogens in the wastewater. Our role at the National Council for Science and Technology is to coordinate these efforts. Please be aware that we are available either to match resources or provide advocacy in order for you and your team to realize your objectives. I thank you.
So thank you very much for that, those comments, and I'd like to quickly add that the two organizations that I put on the screen during my presentation was really just the start, and those organizations for which we have potential investigators. The extent to which engagement or discussion has happened with other organizations is broader than that group, and part of the purpose of including that in the presentation today, which was largely about work that we've done in the past and what we've learned, is looking forward that we're really just at the starting stage. And so being able to present to this group, which would have an interest in the work, but also would have something to contribute is one of the purposes, so that we'll be able to use this as a vehicle to increase the exposure of this project to a greater number of people and organizations, with the hope that others will get interested and have something to contribute, bring their capacity or their particular issues to share. And there are certainly people at the conference. My colleague David Kelvin is there somewhere. He's been engaged in the development process as his postdoc Pacific. And so I'd certainly encourage you to connect with them in person. And then my email was up on the screen, and so you can also contact me directly. So thank you for that question.
Thank you very much. My name is Dr. Zubeida Okundimana, PhD in environmental engineering. I'm interested with this project. This is my area of expertise. So I'm very grateful that you are about to maybe to do this same research in Rwanda, and I would like to be a part of the research team. Okay, my question here is about the findings you have done so far with these projects, where the viruses have been detected in different water treatment systems. What methods, or maybe what have you done to get rid of the viruses, and what preventive methods are you using to prevent their presence in these sewage systems? Thank you.
So I did not spend much time discussing a lot of the testing methodology, instead focusing on what the purpose of the project was, and certainly would appreciate the opportunity to connect you with our engineering side, which has developed the testing side and worked with a private company with industry here to develop a PCR-based testing methodology to actually go from filter paper, which was dropped into the sewer, to the test results itself. And I think we started a process that took about 6 hours or 8 hours, and that's been brought already down to about an hour. So I'm certainly happy to either connect you or directly speak with you about all the different steps that are taken in order to allow that to happen. The second part of your question, I think, probably has two different potential dimensions. The first is the potential risk to those either taking the samples or working with the samples from the pathogen, or the reduction of the presence of the pathogen in the wastewater. And on the first, to the best of our knowledge, with ordinary protection, there's no risk to any of the researchers in proceeding along these lines. On the second, we've not to date applied this approach to looking to reduce the infection within the wastewater. We're using the wastewater as evidence of a prevalence of the SARS-CoV-2 in the human population, which then flows into the wastewater system. So wastewater is purely being used as a surveillance mechanism to try to discern what's happening at the population at large. And so it can also be used in the part of the discussion around the next phase of the project is SARS-CoV-2 is one, but there are a range of other pathogens that are shed through the human system and that can be detected. And so could this project be adjusted to take into consideration those other pathogens? Applying the same kind of approach to the freshwater system. So instead of the system going out, the system going in to sources of potable drinking water would be another dimension to this project, where you're using the underlying technique to detect something that would be considered infectious if ingested through the consumption of potable water. And so that would be quite a different, be very interesting to see how a similar kind of approach could be used as a way of testing the flow of water over an extended period of time, rather than a water sample technique where either through an auto sampler you're taking a small sample over a 24-hour period, or a dip system where you're taking a single point in time water system to look for the presence of something that you don't want in your water, to use the technique to have a continuous sample that then aggregates the potential negative issue that you have in your water over a longer time period. But that's kind of an interesting dimension that would represent quite a modification to the approach that we've taken so far, but really interesting ideas.
Yeah, thank you so much, Stefan, for this brilliant presentation. It was very interesting. I'm Professor Elias Bizuru from University of Rwanda. It's a wish. I would like to ask if it is possible in the future to expand this research in the wild, because we know that many viruses come from the wild animals, and why you are working on viruses and the pathogens from humans, wastewater. I was wondering whether it is not interesting to also monitor the viruses, the pathogens from wild animals and their waste, so that we can build a kind of early warning systems in terms of human health. Thank you.
Fascinating, and I really wish I could be there to have a much longer conversation with all those who've asked questions on this. So the underlying technique is to be able to detect a pathogen over an extended period of time in a pooled way rather than an individual sample or an individual person. So at that kind of conceptual level, there's no reason why the same idea couldn't be applied to the flow of water outside of a municipal sewage system for the purposes of evaluating what has entered into that water-based waste stream, whether it's human or animal. And moreover, it could be for any number of different pathogens as long as it's carried in the water and can be detected through that filter paper system or something that would be modified on it. The one additional matter to consider is the rate of flow of that water. So as I presented in that project, we really have two separate elements for where we have a very high flow environment where there is much water passing through the system, which you would see in a typical Western wastewater treatment plant where you have a significant flow in. The very simple and frankly cheap plastic ball that houses that filter paper, it quickly becomes saturated, or the flow is so swift that the ball actually goes off onto the surface, or it can actually be lost. And so in the wastewater treatment plant itself, we're doing what is much more common around the world, which is an actual water sample. It's actually taken a little bit an auto sampler takes a small water sample each hour over 24 hours, blends it to create a single sample. So that conveys certain advantages where you have a high flow, but disadvantages in that you may miss something. And so the cheap and simple plastic ball model works where the flow is lower. So if we were to investigate how we could transition the underlying method into other circumstances, we'd need to make sure that we were taking into consideration what are the flow patterns, whether it's periodic or constant, and the volume of water, and whether that would affect our ability to test through that method. We have done some comparison studies looking at the two systems, and there's reasonably good alignment between them, but it does depend on how much water you're putting through in order to allow that the sewer cage ball method to work.
Thank you. So with that, thank you very much, Stefan. It was a great talk and inspired a lot of questions. I'd like to turn it over now to Marie Chantal for the closing remarks for today.
Thank you, Stefan, and everyone who presented today. We had great sessions, and I was talking to everyone who was here, and they told me that they enjoyed the session. Tomorrow is another day. We have great session again, and we have in the evening a gala dinner. Don't miss that. So I encourage you to come back tomorrow, and we are going to award our best presenter today and tomorrow. And one of the supports is going to come from MasterCard. So 2 awards are going to be awarded by MasterCard, and we are grateful for that. And then others are going to be awarded by NCST. So we have 4, and we encourage you to be there. Outside, there is an exhibition. There is a coffee waiting for us before we go home. Feel free to grab a cup of coffee, and then again visit the exhibition. RBC team is also there taking the blood pressure, and it's for free. Go and know how your health is, the state of your they told me something and I was afraid I won't go there again, but I encourage you to go there. All right, so thank you so much. We had a good day today, and there is more tomorrow. Thank you so much.